ಇದು ಬಿಟ್ಬಿಟ್ಟು ಬೇರೆದು ಏನಾದರೂ ಇದ್ರೆ ಚೆಕ್ ಮಾಡೋಕ್ಕೆ ಹೇಳಿ ಮೇಡಮ್. ಇವಾಗ ಸೌಂಡ್ ಬರ್ತಾಯಿರೋದು. ಸರ್ ಕನೆಕ್ಟ್ ಇದೆ ಸರ್. ಲ್ಯಾಪ್ಟಾಪ್ ಸರ್. ಅದು ಚೇಂಜ್ ಮಾಡಿ ಸರ್, ಅದು ಒಂದೇ ಒಂದು ಗೊತ್ತಾಗಿದೆ. ಹಾಂ ಹಾಂ
researchers and public
I'm grateful. That's why I want to make an explicit comment. I'm grateful to him because over the years, as you
we have to load so put it in desktop.
I'm just tracking it back. No, you can do it, but that's it. So happy with it.
Vijay Chandru and Professor. Another, no? Another Swami what we don't have. So he didn't send you. Who is Professor Anaswamy? So who knows? Hello, ma'am. It's not on actually. It is on. On, it is on. Duplicate. Yeah, duplicate. No, wait. वो से power off पूछ रहा है. No, lift is something we not have. Because I am not an administrator, that is Pritika's laptop. This is lab's laptop, no? Sir gave her to wait. Better to connect directly to window.
Commonly, most cases are
Screen sharing. But meeting में screen sharing.
It has to be unmuted and then.
I will do.
Yeah, you can come for tea, coffee.
तूने स्क्रीन सेवर भी सेट कर दिया ना यहाँ पे पूरा वो करके रखा है हॉच पॉच डायरेक्ट पे आओ हाँ करिए पेन ड्राइव में घुसो बस वहाँ पे वो वाला वाला मैंने थोड़ा सा सामने लगा हाँ ये स्क्रीन सेवर लगाओ उनको एक सेशन तक यही लैपटॉप देते हैं कहाँ पर है ये तुम्हारा पर डाउनलोड करो ये कल वाला है आज वाला ये है ये मेरे पास नहीं है ये यार बनने वाले मेल आईडी पे जाएगा तुरंत ही अभी आगे सर को बताइए कि हम करके आए हैं कि वगैरह मनोज
you already gave.
Hi, Saman. Can you hear us? Can you hear? Is it connected? Hi, Saman. Can you hear us?
Yes, we can.
Okay. Oh, thank you. Thank you, Partha. Thank you. Yeah. We'll just,
Hi, Mani.
Hi. There will be a small video presentation first, then after that, your talk. Okay? Thanks.
Sure.
Hello, good morning, sir.
Good morning, Kunal.
Hello, good morning, Saman, sir.
Shall I play? Yeah, you have to. Shall I play?
It's okay, I'll just
Okay. Then we have to press this.
Yeah, this one. Yeah, yeah. Welcome back. We are honored to share a special video message from Dr. Kiran Mazumdar, founder and chairperson of Biocon Foundation.
Good morning to all my esteemed colleagues, clinicians, researchers, and public health champions. It is indeed a privilege to address this gathering on the World Head and Neck Cancer Day 2025, hosted at IISc. Today marks more than a commemorative event. It signals a pivotal shift in our fight against oral cancer. With over 75,000 new oral cancer cases and over 50,000 deaths annually, I repeat, 50,000 deaths annually, India bears one of the highest burdens globally. Alarmingly, most cases are detected at advanced stages when outcomes are poor and costs are high. We must change this trajectory. This year's theme of the Oral Cancer Task Force meeting, Ideate, Innovate, Implement, reflects our collective resolve to take action leveraging technology, research, and grassroots insights to drive prevention, early diagnosis, and scalable solutions. Biocon Foundation has long championed this cause at the community level. Through over a decade of field engagement, screening thousands of people, building capacity for the public health system, we've seen the deep structural and behavioral challenges firsthand. The creation of the Oral Cancer Task Force in 2018, built on this foundation, brings together partners from clinical, academic, technological, and public health spheres to develop more integrated and impactful approaches. Today, we take the next step. Our deepened partnership with IISc marks a powerful convergence of scientific pursuit and social commitment. With IISc leading the next phase of OCTF, we are creating an innovation ecosystem focused on AI-led diagnostics, bioinformatics, and accessible technologies tailored to India and not just other LMICs, but for the whole world. At the same time, Biocon Foundation will continue to partner the Oral Cancer Task Force as a part of its commitment to advance evidence-based clinical practices through its annual consensus guidelines, supporting standardization of care across the country. I believe at OCTF, our vision should now stretch further, from control to elimination. As all the teams at OCTF begin drafting a white paper on oral cancer elimination, we are putting forward a bold but achievable ambition. This will demand visionary leadership, a data-driven framework, and cross-sectoral accountability. I'm glad to mention here that we are not starting from scratch. We have the expertise, the commitment, and the tools within OCTF, within IISc, and among all other partners gathered here today, which need to be leveraged to meet our shared purpose. Let us approach this World Head and Neck Cancer Day 2025 as an inflection point in the journey of OCTF and take a collective call to reimagine what's possible in the fight against oral cancer in India. We must eliminate it. That's our resolve. Thank you.
Grateful for the video message from Dr. Kiran ma'am. Her insights are truly valued. We now proceed to our next keynote address on global approach for prevention, screening and detection of head and neck cancer, chaired again by Dr. Moni sir. I invite sir to moderate this session.
Good morning again. So we will have two keynote talk in this session, and the first keynote will be given by Professor Partha Basu, and after the second keynote there will be a brief comment by what Professor Varnakula Surya again will be giving remotely, and Partha Basu is going to join us by Zoom on the call. Now, just to introduce Professor Partha Basu, he is a gynecological oncologist by training. He is the head of Cancer Prevention Division of IARC of WHO. He has done multiple early detection trials, prevention trials throughout the globe. His seminal work showing that single-dose HPV vaccination is effective is really groundbreaking. Over to you, Partha. Partha is going to join us from Lyon, France. Partha, can you hear us?
Thank you so much, Moni. Yes, I can hear you, but then I need to share my screen.
Yeah, 1 minute.
So, should I try?
1 minute, okay. We have to stop sharing here.
Yeah, maybe now I can.
Yeah, over to you. We can see your screen.
Good.
Can you put it in the presentation mode, please?
Yes.
Thank you. We got it. Yeah.
Right. Good morning, everyone. In this talk, I wanted to be a little provocative in selecting the topic. As you can see, my statement is that organization of the screening program is much more important than spending hours and hours deciding on the screening test. We know in India, the non-communicable disease screening program was launched way back in 2010. Over the last 15 years or so, it has gone through several evolution, different naming procedures. There was a pilot supposed to be implemented in 100 districts. We have never seen the data of those pilots. But then we know that this non-communicable disease screening program aims to screen men and women above 30 years of age for diabetes, for hypertension, oral cancer, for women breast and cervical cancer. Very ambitious program. But then we need to ask ourselves, what is the impact of this program, which is going on for the last more than 15 years? We can see the annual percentage change in the incidence of different oral cancers, tongue cancer, mouth cancer. I'm showing you the data. It is in most of the registries, it is showing a significant annual percentage increase in incidence, and there is no evidence that oral cancer mortality is reducing in the country. So before going into the issues related specifically to the screening program in India, let me present you the evidence that came from the very seminal study, the Trivandrum oral cancer screening study that was led by Dr. Shankar Narayanan, Dr. Ramadas, and this large randomized study, it had a cluster randomization design. In one cluster, nearly 100,000 men and women above the age of 34 years. They were screened with oral visual examination. Now at IARC, we are calling it clinical oral examination because it's just not visual, but then there is a component of palpation as well. And there was the control group, almost similar number of participants who did not have any systematic screening, but then they had health education. And the studies that was initiated in 1996 was followed up over the next 9 years, during which time there were 4 rounds of screening offered every 3 years. And what you can see here is that as far as the impact on incidence and mortality in the entire study group, the oral cancer incidence ratio was, yes, in the intervention arm, it is showing that there were more oral cancers detected, but it was not significant. There was evidence of downstaging, again not significant, again non-significant reduction in mortality. But then if we look at only the men and women who are users of tobacco and alcohol, there we see the significant downstaging of the disease, as well as 24% reduction in mortality, which is significant. I'm sure Anil has already presented to you the work that we did together to look at more risk stratification, where we do see a significant benefit of oral cancer screening by the trained community health workers. And another thing I would like to highlight that came out from this study is, you can see that the screening benefit started to be seen after 3 rounds of 4 rounds of screening. So it is screening, as we all know, it is not a one-time intervention. It is a repeated intervention that has to be done in the same population over a certain number of years. Now, this is the evidence that came from randomized controlled trial, where everything is very controlled. Now, what is the evidence that it actually works in a real programmatic situation? As I said before, unfortunately, there is very little publication on the impact of oral cancer screening in India, though we have a national program running for so many years. But then in Taiwan, also they have a population-based organized screening program. The word population-based, it indicates that there is a system of invitation, that the target population are systematically invited. The opposite to population-based is opportunistic screening. We need not always think about population-based screening, which is I call as the Nordic country model, because very few countries in the world, excepting some of the European countries, Canada, Australia, very few countries have actually been able to implement such a population-based program. So I'm not against a high-volume opportunistic program supported by good awareness campaign. But then there is another issue here, that is organized screening program. I will come to that, what we mean by organized screening program. And in this particular program, they targeted men and women who had the habits of smoking and metal quit chewing. Unlike in India, where we are targeting all, they are essentially targeting the 30 years plus, but then in certain group of men and women, indigenous population who are known to be heavily using metal quit, they have been they are also screened after the age of 18 years. Now, you can see the overall screening participation reported was more than 50%, which is not too bad. It showed a significant 17% reduction in incidence of oral cancer. Essentially, we know because of the detection of the oral pre-malignant lesions and treating those lesions. That is important. Screening, again, is a continuum of multiple processes that starts from offering the screening, but then also its most important thing, evaluation of the screen positive men and women, and making sure that they have access to treatment. And here again, they have seen the mortality reduction, which is significant, and also they have seen the reduction in incidence of advanced oral cancer. Essentially, that's a surrogate for a reduction in mortality. So this particular study shows that if we can implement screening with appropriate quality, appropriate organization, adequate coverage, it is feasible to reduce the mortality from from oral cancer. Screening, making a decision related to screening is always, it's based on pragmatism. It's screening, yes, it does have benefits, but it also has harms because of false positives, because of false negatives, and men and women getting false reassurance. But then we also have to think about that screening being a very complex public health intervention, it produces a lot of burden on the health services, both in terms of logistics as well as fiscal burden. So until and unless there is a very clear benefit, balance between benefits and harms, we do not recommend screening for different cancers. Say, for example, we don't recommend screening for liver cancer because of this harm-benefit issue. So for oral cancer screening, is there any benefit? We at IISc, we published a few years back a handbook on oral cancer prevention, and we found that screening for oral cancer in the users of tobacco and alcohol may benefit and may have significant reduction in mortality. Please note the wording may. And then it was considered as a grade B evidence because there was only one randomized control trial, and the other trials we have seen a lot of heterogeneity. Coming back to the organization of the screening program, where exactly we are lacking in India. The screening program is like a jigsaw puzzle, and there are multiple pieces in that jigsaw puzzle. A few years back, we brought together global experts and asked them to identify what are those elements of organization of screening program, and we put them in the context of health systems. So the health systems requires leadership, governance, and finance. So here, what is important is to have a policy framework where there has to be a rational protocol. We really need to think our protocol of offering screening to one and all, starting at the age of 30 years, and then every 5 years, is it really rational? Health workforce, having adequate training of the service provider. If you look at the operational plan of the NPCDCS, it says that the health workers, they will be trained for VIA, for oral visual examination, for clinical breast examination within a few days of 3 or 4 days. I've forgotten exactly, but then that is highly inadequate. And then most important thing is access to essential services, and of that the most important is taking care of the screen positive individuals, having a very clear referral pathway where they are going to go, where do they get the further evaluation. Most important thing is where do they get treatment which is free of charges. In India, our public health system does not charge money, but then there are so many structural barriers for these men and women to access further evaluation. It becomes a huge amount of problem for them. And the most important part of any health program is to have a quality assurance system. So that which is again totally lacking in India. What do we understand by quality assurance? It is essentially measuring the performance of the program using certain performance indicators. There are structural indicators, process indicators, outcome indicators. But then what is important is to measure those indicators on a regular basis. And for that, what we need is a robust health information system that captures the data so that we can estimate these indicators. I mean, it need not be as ambitious as we are in European Union, where there are several indicators, but then some of the key indicators. What is the examination coverage? What is the screen positivity? What is the compliance to further assessment? What is the detection rate of oral pre-malignant lesions as well as cancer? These are the very important indicators to be measured. And to do that, we need robust data collection. Unfortunately, I have searched through all the health ministry, websites. There are other, websites that collects different health program data, and this is the best I could get. You can see it is giving the I've just listed the states that are screening more than 1 million. Men and women for oral cancer. You can see some of those are, screening 28 million. But then where is the data for those, for those men and women? What is the skin test positivity? What is the detection of disease? There is absolutely no data. So maybe what we get from the National Family Health Survey data, probably that gives the real picture. Less than 2% of men and women, they have ever had screening, and that too once in a lifetime. This National Family Health Survey data does not ask them whether you get it every 5 years or so. It is once in a lifetime, and this is what is the real scenario in India. And no wonder that there is no impact. So what we need to do, we need to get our act together. If we really have to improve the organization of the cancer screening, we need to have a quality assurance protocol where there has to be specific indicators listed. And more important thing, there has to be a protocol of how to collect the data on a regular basis and analyze that and take action on the basis of that data. We need to rationalize our screening protocols. Again and again, I'm focusing on the fact that management of the screen positives, that is the most important part of any screening program, because it is unethical to tell men and women that you may have cancer but not taking care of them. There has to be a tracking system. At least in India, we have our huge capabilities for developing information systems, and we have shown that during COVID. So why can't we have a proper system that will allow the program to track the men and women who are detected to be positive? And then, as I said, our training plan has to be rational, because we need to understand that clinical oral examination is highly subjective examination. So we need to make sure that there is enough training of those community health workers or other persons who are supposed to do the screening. And finally, we need to make sure that the focus never comes out of primary prevention of oral or head and neck cancers. And that is how it will give us the biggest dividend over time. Thank you so much for your patient listening.
Professor Basu, thank you very much. Any questions, comments from the audience? Please use the microphone. Yeah, one question in front. Just say who you are, and then Dr. Basu can answer.
Sir, good morning, and this is Dr. Divya Khanna from TMC Varanasi. Sir, we have seen the questions that have been asked in NFHS 5 with regards to screening coverage, and that to in various vernacular languages. So they have used two terminologies in their questions. One is, क्या आपके मुंह के कैंसर के लिए, and the term is oral cavity का प्रशिक्षण किया गया है. So most of the Indian population may not be understanding what is oral cavity. And the second question was कि क्या आपका cervical cancer के लिए प्रशिक्षण किया गया है. Most of the Indian people won't be knowing what is cervical cancer, this particular medical terminology. And this has been a part of fallacy in the NFHS 5 questionnaire that has been asked. We checked upon this from the website now. This PDF is not there. And that's what we have published. So I'm wanting your comment on whether actually the NFHS 5 is given the correct coverage.
Yeah. I mean, as I said, obviously, the data that we get even from the survey is very weak. And I mean, 1% coverage, 2% coverage is almost like zero coverage. And then we have been implementing different community-based studies over many years in different parts of India. And all the men, women, when they come for any kind of checkup, in the study, we always ask them whether they have ever been screened, and we almost zero proportion of those men and women have ever been screened. But having said, I mean, more important to me, more important than the coverage, as I said, are the downstream indicators. What is the positivity rate? What is the compliance of the positive for further assessment? What is the detection rate of disease? That is something nobody is even focusing on. Some, our ministries, if you look at all the operational documents that are shared with the districts, with the primary health care, they just simply want to collect how many have been screened. That does not tell us anything.
Thank you. Any other questions, comments?
Yes, good morning. My name is Niket. I am from this institute, IISc. So I have first question regarding, I have first question regarding curing. Like, generally when we think about cancer, then it's very difficult to cure. So can you give proper insight on how difficult it is to cure cancer? Because I think most of the people don't come for screening because the thing is, when somebody detects, okay, he has the cancer, and the person already know he is chewing tobacco, so he will have general conception that he will come into a cycle of visiting the doctors, and also it will be very difficult for him. So how difficult it is for curing cancer? And second question is regarding prevention. Like nowadays we are talking so many things regarding prevention, cure. So is there any kind of like can any vaccine be developed, because so many people just want to chew tobacco? So is there any thought about some vaccination or anything, or any other alternative in which it can be cured? Yes, thank you. Okay, thank you for giving.
Thank you for the question. Indeed, cancer, including all head and neck cancers, can be treated and cured, provided they are detected at an early stage. And then in the audience, there are many head and neck cancer surgeons, those who treat head and neck cancers, so they can give more insights. Certainly, stage 1, stage 2 disease can be cured. But more important is the fact that this cancer has a pre-malignant condition, which if it can be detected and treated, we can prevent the progress to cancer. So that's one of the major focus of oral cancer screening. Same is for cervical cancer screening. We want to detect the pre-cancer stage and want to treat it. And as Pankaj has already mentioned about the vaccine, yes, the vaccine, as far as the head and neck cancers is concerned, it is only as evidence that it can prevent the oropharyngeal cancers, which is not yet a burden in India. So, this vaccine is not essentially targeted for oropharyngeal cancer. Yes, it can benefit because the oropharyngeal cancer is associated with HPV infection, but then the huge benefit of the vaccination is in prevention of cervical cancer and some of the genital cancers. So we should, when we are thinking about primary prevention, we should think about other measures to prevent use of alcohol, prevent use of tobacco, focusing on oral hygiene. So these will pay much more dividend.
Thank you, Dr. Basu. Let me request Saman Varnakul Surya. He has raised a hand. He is the professor of oral medicine at King's College, London, and he also leads the Oral Cancer Center, WHO Oral Cancer Center. Saman, over to you.
Thank you, Moni. Good morning. Thank you, Dr. Basu. You kindly highlighted the weaknesses of the programs which are currently ongoing. What are the main recommendations you will bring forward, or is it possible for IARC to put a roadmap? What is the way forward for reducing the incidence of oral cancer in India?
Thank you, Professor Saman. IARC, as you know, IARC is not the policy recommending organization. Technically, we are evidence. What we do is we generate evidence, we synthesize evidence, put forward to our colleagues in the WHO so that they can come up with the recommendations. So IARC handbook, as I said, our evidence shows that yes, screening for oral cancer may reduce the incidence as well as mortality from the cancer. But then we also have to think about all the heterogeneity of the studies, and then the fact that only one randomized control study has shown. So the level of evidence is not that robust. So that is why we say may reduce mortality. And as you very well know, till now from the WHO, there is no recommendation for oral cancer screening. Having said that, many of the countries with the high prevalence of use of different chewing practices, they are like, as far as I know, Sri Lanka has gone for oral cancer screening. The Thailand, Taiwan, Cuba, these are the countries across the globe. They are implementing oral cancer screening. May not be in a very organized, very high volume screening, more as in pockets. But then the recommendation from the WHO is that at the present moment, the WHO, there is no recommendation for oral cancer screening.
Thank you, Dr. Basu. I recognize the presence of Dr. Sokching Chow. She leads the oral cancer control program of Malaysia, and Dr. Kunal and several others. So in interest of time, let's move on. Sorry, one more question. Yes, Partha, you're very popular. Yeah.
Thank you, Dr. Partha. Prabdeep here. Nice to see you after a long time. We always meet mostly in cervical cancer meetings, maybe first time in oral cancer meetings. So my question actually goes to your presentation. I mean, of course, I support all the ideas of having better implementation and worrying less about, we can always figure out the technology part of it. So I think from my experience of having worked with India's NCD program, I feel that I have not seen presence of the oral cancer community really on the ground in the program at all. I think I'm sorry to say this, oral cancer experts meet each other and they talk and they have written very nice papers. But when you get on the ground and you really work with the health system, I see a lot more presence of, let's say groups from gynecology trying to push, let's say, for colposcopy, biopsy, and things like that. But I feel that there has been a complete lack of connect between people who are actually doing very good oral cancer work in their centers of excellence and their connect with the national program. So given your experience, what are your thoughts on that, since you have a lot of sort of opinion leaders here in the room? And secondly, I feel that there has been no effort actually to improve the referral pathway. I mean, I'm not talking from only program perspective, but also like, have you expanded the pool of people who can do biopsy, let's say for oral cancer? I have not seen any effort. And yesterday I had a very good talk with Dr. Deepika on this, and I was telling her that NHM, actually if you go into the maternal health program, recognize that there weren't enough people who could do, let's say, cesarean section or anesthesia. And they came up with the, an abridged program, and the MBBS doctors were trained to give anesthesia and to do the surgeries. So what are your thoughts on that? Because see, going on saying that the government should do this, government should do that, we don't have pool of doctors, even dentists, who can do biopsy. So even if you do the best screening program, it's going to be a failure at this stage, simply because the next level is missing. Thank you.
Thank you, Dr. Prabdeep. Thank you for your comments, which are very pertinent. And then I fully agree. If you think about the health systems, WHO health system concept, there are 6 components. First component is coordination and governance. So there has to be somebody who should be responsible for implementing the program at the state level, at the national level. There must be, I'm sure it is there, they are there. But then they need to bring in all the stakeholders together. In the stakeholders, it's just not the oncologists who are managing the cancers, but then also people in the ground try to understand what are the ground reality, what are their challenges. So in Europe, we are coming up with several screening recommendations. One of the major recommendations is screening program being such a complex program. Before you roll out the program at a national level, run pilots in an area, learn lessons from the pilot, publish the results of the pilot, and then gradually scale up across the country. In India, we have never done that, though there was a pilot on paper in 100 districts. We need to really measure our performance and try to understand where are the bottlenecks. Thank you.
Thank you, Dr. Partha. In the interest of time, let's move on. Next keynote will be given by Professor Vijay Chandru. Dr. Chandru doesn't need an introduction here. He's an alumni of Indian Institute of Science, a computational biologist by training, a serial entrepreneur, started Strand Life Science, CRISPR Bits, Yantri Labs, Biovigilance, and so on. And he is most recently is the commissioner for the Lancet Commission for Reimagining Indian Health. That's going to be published very soon. Professor Chandru.
Thank you, Moni, for that kind introduction. I've noticed that in the program this year we've alternated between clinical and technology, and this will be a technology talk about a new platform and that I believe has potential, and and I hope we will get to discuss the right kind of applications that could help with head and neck cancer. I don't believe I have the expertise to really take this forward, but in consultation with the thought leaders here, I think we can. So my talk will be a little bit more about the technology and the platform and why it's interesting, and then we can perhaps have more discussion. So, yeah, I think Moni introduced me as an alum of this institute. It's sort of, this institute is my anchor, right? I've been here for 35 years, and whether you think of Strand or any other journeys, those have all been linked with the institute, the first translational programs of the institute, right? So I'm still here. These days, my affiliations are with Art Park and with the Center for Brain Research. Yeah, I'm all over the place. So I think I'm going to sort of do a continuation of Ramesh's talk a little bit, right? If you think about, that's, yeah. Okay. Oh, you were setting it, right. So back in 2000, a bunch of us here at the Institute felt that the Human Genome Project was going on, and one needed to actually build a capability around genomics. And as Moni might recall, I think we set up the first labs, sequencing centers in India at Ganit Labs, and collaborated with Moni on sequencing the first tongue cancer in the world, right? And the first whole genome sequence. At that time, it was going to cost us something like $40,000. And so Dr. Devi Shetty and I found the budget somehow to fund that project. And as Ramesh pointed out yesterday, the cost of a whole genome sequence today is roughly about $250. If you use the latest technologies and the right platforms, like at Strand, he has now set up the NovaSeq X Plus, and at Karkinos, you have similar facilities. And so for roughly about 20,000 rupees, you could do the same thing that cost in those days, 20 lakhs, right? So, so that some of these technologies have that very rapid exponential improvements and cost reductions, which suddenly make them very relevant. And you have to start, and these platforms become relevant. So Ramesh, then I think, talk towards the end about some work we did for oral cancer at Strand. And that came just after this oral cancer task force was put together in 2018. And Strand was working on liquid biopsies. And so then we were approached by the Tata Trust and by, Tata Memorial, Actrec, and Nishant Agarwal from Chicago. And we did this genome sequencing of using saliva as the sample matrix. And Ramesh mentioned towards the end that perhaps now it is time to not just look for mutations in that saliva sample, but to look at methylation patterns, because those tend to be better markers for early detection, right? So I think, that story continues, and I think it can be probably taken forward. But today I'm going to talk about, instead of sequencing, the use of CRISPR, right? When I handed off the baton to Ramesh to run Strand, I felt that we had done quite a bit on genome reading, and I thought it might be interesting to start thinking about genome writing, right? And gene editing. So for those of you who know this is of course just very introductory, but it's probably in the history of science there hasn't been a technology that has advanced as rapidly from first discovery to Nobel Prize, right? Doudna and Charpentier, who published the work in 2012, by 2020 they received the Nobel Prize for it, right? So, of course, one can say AlphaFold is also one of those quick things, but this is, and the idea is that something that occurred in nature, because bacteria figured out how to protect themselves against viruses, actually then results in a technique, a technology that allows you to find a pattern, cut at that pattern, right? And that's the discovery, CRISPR-Cas9 discovery. And it leads to two types of use of CRISPR, for cleavage and for cis cleavage and for trans cleavage, right? And to explain that better, here is an actual electron microscopy visualization of CRISPR-Cas9 in action, right? This is cis cleavage, and basically, with varying efficiency, in seconds, it actually achieves the cleavage, right? This one takes about 1.5 minutes. I think the second time around, and sometimes it does it in 20 seconds, sometimes it takes 90 seconds, and so on. So the efficiency varies, and that's actually a very nice problem to think about from a science point of view. I believe that quantum chemistry is going to tell us more about how the efficiency of cleavage actually occurs. And so for those of you who are interested in quantum, I think there are some very interesting simulations that can be done. Trans cleavage is a little different. It finds the pattern, but then it becomes like a Pac-Man. So you can have reporters, and any nucleic material will get cleaved, right? That particular enzyme encounters. And so then you'll get, like, you can put a reporter with a fluorescent marker, and you get a fluorescent signal that you can read. Or you can use biotin and use a lateral flow, various ways in which you can read off. People are now working on electronic ways of reading that signal as well, right? So, so I think this, now I won't, I think, these movies tell the story much better than, all the words, but basically this is a little bit about the company CRISPR Bits, so I won't dwell on that. But just to say that we've been working on three different uses of CRISPR. One is for, for diagnostics. So we call that path CRISP. EditCRISP is to do precision genome editing, and these could be on microbes, on plant genomes, for industrial applications, for environmental, etc. And CurieCRISP, and of course we also create a lot of knock-ins and knockouts for various model systems to be studied, right, for academic researchers. So that's part of it. And CurieCRISP will be the question that was raised, on cure and, whether there can be some approaches to improve cures with CRISPR. But today's talk is primarily focused on the diagnostic part, which is path CRISP. So the idea is the following. You could collect samples. These could be swabs, blood, and of course, for other applications, you could be looking at food, and if you're looking for food contamination and so forth. And then you talk about amplification. Now, the traditional way to think about amplification is with thermocycling, maybe PCR. But it turns out that these days we have isothermal amplification methods like LAMP and RPA and so on. And so that allows you to actually be very light on instruments, very low resource settings. You could actually be doing these amplifications. And finally, you get the actual readouts, right? And now imagine what we're trying to combine now is a SARS-CoV-2 test, for example, that you had to go to an RT-PCR to get a confirmation, but you had a COVID self-test that you could do at home. What if you had the same power in that COVID self-test? So I'm actually want to put that thought in your head that the advances in molecular biology are taking us towards the idea of self-testing, testing at home, testing at the point of need. Okay? Let's stop talking about at the point of care. Let's actually talk about at the point of need, right? And how do we build platforms that take us to the point of need, right? And essentially, one of the components here is that how do you combine all the reagents of LAMP and CRISPR detection, lyophilize them so that you get independent of the cold chain. These kits can go anywhere, right? They can be packaged, and eventually they can be put into an electrowetting or a microfluidic chip. So this can actually do multiplexed testing at the point of need, right? That's where this technology should actually lead us. We may be 5 years away, maybe 10 years away, but I think we need to make a start, right? And so anyway, the PathCRISP platform is kind of ready now. We are using it for AMR diagnosis, gram-negative. Started going into ICUs at St. John's and CMC Vellore, several hospital partners, and we have been particularly focused on NDM, but we will be looking at all the major pathogens and the AMR markers associated with, unfortunately, the AMR silent pandemic that has gripped the country, right? We have also, of course, there's been a national, sort of programmatic effort now on sickle cell, and so we've also used CRISPR now, where we're able to differentiate between heterozygous and homozygous. So we can call out carriers versus actually full sickle cell disease, again with this technology, and this is also now in clinics, right now being field tested in Mumbai. right? And on prenatal samples, CVS, and so forth, right? And we're getting pretty much, by the way, there is a lot of research and cleverness that comes in the selection of the guide RNA for a CRISPR test to work. And that's actually a reinforcement learning problem. It's because if you just use a simple bioinformatics sort of guide design just based on a target pattern, that does not necessarily work in the lab, right? So there is some art to this, and it's gradually, we are building, and many people are doing this, building rules and rule-based sets to be able to start using machine learning in actually designing these guides. But we are at a point now where if you give me the pathogen, in about 2 to 3 weeks, we'll have the guide designs. We'd be able to get them. We can order them through many reagent providers, and we can start testing in the lab, right? So it's so that's what I'm hoping. By the way, this battery is running low, so somebody needs to make sure it's plugged in, right? Yeah, let me. I think only I'm seeing the signal. I think they had switched laptops for the. For Kiran's message, so yeah, they're back. Yeah, thank you. So yeah, I think I already talked about this, and this is the whole lyophilization process, and again, this is very cool because essentially you can create, you can freeze dry the entire mix, and then all you have is powder. Then you can take crude sample and buffer and just get the test going, right? It's quite, and this has actually survived. We've taken these kits in our baggage to Mumbai on the checked-in baggage, stayed in a hotel room overnight, and the next day gone into the clinics and used them, and everything is fine. It works, right? So I'll just end now by saying that, of course, what we want to do is try to figure out how this platform could be of help in head and neck cancers. Of course, the obvious ones that show up in the literature when you look is HPV and Epstein-Barr virus as sort of two pathogens implicated. But from what Dr. Chaturvedi said this morning, I think we should really be thinking now about a panel of maybe pathogens. You were mentioning, actually looking at the oral microbiome and trying to see whether that, combined with the mutations or methylation patterns that one gets from saliva, how all of this can come together to give you very good, evidence for early detection and prevention. So I'll leave it at that. Thank you very much. Right. No, they should be. Yeah, to repeat the question. Saliva as a matrix, would that be a challenge? I don't believe so. Right. Yeah. I think we'll of course have to do some experimentation, but the sensitivity is so high. For example, with Salmonella today, we are detecting a single copy in milk, right? So it has that sensitivity to be able to pick up at very low copy numbers, right? And so, of course, with anything to do with saliva, the collection, you have to be careful with any rinse because of, food particles and so on, as we saw even in the test with Tata Trust. But as long as you do that preparation, and by now, there's a lot of good evidence on how to do genomic testing with matrices like saliva, where, I think Strand now and MedGenome routinely do all our germline testing with saliva samples. So,
and multiplexing is feasible, is it?
Multiplexing is feasible. It requires this. Right now, we can multiplex because we can take, for example, a heat block, and we can put 16 of those tubes in there, right? And we can run 16 tests. And the reagent cost for each of those tests is less than 100 rupees, right? It's about 60 to 70 rupees for each kit. So I mean, this is in that realm where this could be the next generation for qPCR. Right? I think that's the point. I think eventually sequencing will completely push out microarrays, right? And we're already seeing that chromosomal microarrays versus low-pass sequencing. It's very clear that you get better signal from low-pass sequencing for the same cost. And I think similarly, PCR will get replaced by multiplexed. CRISPR is the belief, right? And that's a technological bet, but that's the bet we are working on. Right? So.
Thank you, Professor.
Sure. Can I ask you a question? Sure. Yeah. So I'm Dr. Praveen, and I look at the medical affairs of Biocon Biologics. So a very great talk. Quick question on this is that, what is the specificity of this particular test? Now we are going to take this up. That's
right.
yeah.
Right. So so far, just to give you a sense, we went to. We are doing everything testing against with gold standards, right? That's how we're building the evidence. So I think I showed something on sickle cell, for example. We had 21 samples at Lilac Hospital in Mumbai, all checked against Sanger, and CRISPR called out correctly on 20 out of 21. And one of them, it turned out to be a pipetting error. So we'll have to publish, larger studies. We're going to CIDESCO. We're going to FSSAI for the food products. It's all, in that process now. The platforms are ready. And I think with NDM, and the MR markers, our study was published in scientific reports and in Nature just this January. So there was enough evidence and data published there. So right, sure.
So just a comment on what you asked about. I think what is very critical at this point, with the current evidence that we have, once we see something in the oral cavity, actually the pathway is very clear. You have to do biopsy, you have to do excision, you have to do cessation and all that. What is not known and what is true problem, what Anil was presenting, that the population, which is the high-risk population, potential to develop cancer is huge. I think we need to focus on when nothing is seen in the oral cavity, yet there is a risk. Right. So I think this can be a very good tool in high-risk high-risk people to do the salivary biomarker, which is a combination of the exfoliated cell as well as the microbiome, right, for the risk prediction who is likely to develop pre-cancer, right, or cancer.
Yeah.
So this can be a very simple point of care device for that setting, and I think we need to do a research on that.
Sure. Thank you. Thank you. No, absolutely. And I think yesterday, after Ramesh's presentation, someone made the same comment about exfoliated approach, because I think there is, there's probably you'll get more sensitivity when you have exfoliated cells. So, thank you.
Next, we're going to move into a very exciting discussion. Our chairperson challenged us this morning by elevating the bar that we should no longer talk about controlling the oral cancer. We need to talk about the elimination of oral cancer. Pankaj also reiterated that thought. But to do that, there should be objective targets, measurable objectives should be there. To guide us the discussion, I request Praveen Bairud to moderate that discussion. And before Praveen starts, let me on the call we have Professor Varnakula Surya. If you can stop sharing 1 minute.
Thank you, Moni, and thank you, Praveen. I think this is a very important point. We have been talking about reducing oral cancer incidence by 5%, 10% in the past, but now we are moving to discuss elimination of oral cancer. That's a very important target. Looking at what has happened in the past, particularly the national screening program, which was mentioned by Dr. Basu, I think it's important to do a SWOT analysis to understand the weaknesses of the screening program so that we can make adjustments to improve the compliance. For example, if you take the compare the compliance between the national study, less than 4%, with the Taiwan study, close to 50%, we need to understand the weaknesses of the national screening program if we want to go ahead and recommend screening at a population level. So there is a lot to be done, and I think it's a great idea that we are progressing elimination of oral cancer in India, because we have been talking about, we know the risk factors, we know the populations involved, high risk groups, but action is needed from all areas, and training dentists to get involved in oral cancer screening, identifying high risk populations is the most important step we have in front of us now. So coordinated effort, I'm glad that Moni's group is taking this forward, and we are happy to contribute to it. I was the co-chair of the Oral Cancer Handbook from the IARC, which was published last year. And I think there are reasonable amount of evidence in that which can be taken forward to contribute to the elimination of oral cancer in this region. We also published the special issue in oral diseases highlighting the important aspects of prevention, and both primary and secondary prevention. And I think we have enough evidence on the table to take care for the future. Thank you very much.
Thank you, Saman. And Professor Shankaranarayan sir could not join because of personal reasons, so requesting Praveen to take the proceedings forward.
Thank you, sir. It's indeed a privilege to lead this session. When sir sent me a mail, it's elimination, I took 2 steps back, been struggling with screening and detection, and then elimination comes. So I'll quickly set the notion by a few of the oral cancer task force, how it was formed and what about. And then from Professor Anil, who gave a microsimulation modeling. It's more on the assumptions. And I also understand that as we work on assumption, we can also work on the actions. So quickly on the oral cancer task force activity, I think the idea was, this was, sorry. Yeah, thank you. Full screen. Leave it also. Thank you. So the task force which was formed, of course, we started some sort of an technological intervention to help the conventional screening. The whole idea in 2018, when Pankaj sir stated that we need to form a group and move ahead, because there was some amount of activity happening right from 2010-11, then it was formally experts joined in to ideate, educate, engage the stakeholders, because that was one of the key areas, so that all of us come together rather than working in silos. And to downstage oral cancer, of course, was the main objective. So objectives formed at 2018 is still, we are happy to change or modify or edit as we move forward. It's nearly 8 years from 2018. So educate and engage, it includes all the stakeholders, from the healthcare workers to primary care physicians to the general dentist to public. Technology leveraging was the key component of the task force, so that how do we get together. And the active component came from research and innovation, and with multidisciplinary experts, which we have from surgical, medical oncology, radiation oncology to the public health specialist who can work together. So this was the idea which the task force was formed, and we have done some significant, or at least a work forward from what it was been there. But the task force members generally give the guidelines to how do we move forward year by year, and there are some amount of activity across India. So leveraging technology, though it was at different levels, I'm so glad that at this point in 2025, we have Indian Institute of Science to be a part of this. So its secretariat of the Oral Cancer Task Force will be Indian Institute of Science. And I'm sure this gives the most required impetus to move forward for the ambitious project of elimination of oral cancer. So the terms of references is leveraging technology and partnership, framework for operational control and measurements of the impact, relevant benchmarks, synchronizing oral cancer efforts with a broader national contact control program, update skills of healthcare professionals, establish an environment to reduce the risk factors, strengthen the National Cancer Registry, and map the tertiary centers. So I think if you look at the way we have worked, the Mazumdar Shaw Center for Translational Research and Foundation is where the bench research is done. Biocon Foundation takes it to the field. And there are nodal centers like KLE and many other centers which leverage and bridges these two gaps. And that comprehensive approach, I think, has given us the much desired way to move forward. So with this, expected outcome was to make a cost-effective, patient-centric oral cancer control program. Now this year, annually we release a consensus guidelines steered by Kumar Prabhash sir from TMH for head and neck management of oral cancer, head and neck cancer. This year, ambitious effort is to get into elimination. So we are probably discussing the synopsis kind of a thing. What is the framework and how do we plan for elimination of oral cancer in India? So the idea came from the cervical paper elimination of 90-70-90. So to reach the 90% of population who are at risk, screen at least 70% of population who have been identified at risk, and at least have the referral or initiation of treatment of 70% of people who have been screened. So with this ambitious project, we approached multiple people, multiple stakeholders, Professor Partha Basu, Professor Samanvarna Kulasurya, PC Gupta sir is here. The stalwarts who have worked from decades on screening and detection. And there was multiple exchange of ideas, discussion points. And we have arrived at finally at some sort of a framework for synopsis. I sincerely thank Anil for his, to give a shape to how do we move forward. And three of my colleagues have worked on that. So we will start with what the synopsis is, and intervention 1, intervention 2, intervention 3. And there are some data supported in the literature for all the 3 interventions, and we'll open for discussion. So Shubha, if you can start. Thank you. where is the second one? Sir, if I call onto the dais, I think you can't see the presentations. Sit here? Okay, thank you.
Good afternoon, all. I'm here to present the synopsis of white paper on oral cancer elimination in India. So time and again, we know India is estimated that in India, it is estimated that annually about 77,000 cases are being reported, and amongst them 52 deaths annually are being reported, accounting to about 1/4 of the global incidence. The incidence of oral cavity cancers is high in India and highest amongst the globe, accounting for about 30% of the worldwide burden. Oral cancer is the most common in India, and it is reported first amongst men and third amongst the women. The key aspects of this synopsis is that cessation of risk behaviors, that is tobacco, arecanut chewing, smoking, and heavy alcohol drinking. The second, screening and treatment of oral cancer precursors such that leukoplakia, erythroplakia, oral submucous fibrosis, and histologically based dysplastic diseases. These could reduce the risk of oral cancer. Screening for detection of oral cancer at early stages, which are treatable at that stage, has been shown in Kerala trial study to reduce the risk of oral cancer mortality by 27%. Kerala trial also showed that 75% of such screening is beneficial, and in 20% of individuals at highest precancer screening risk of oral cancer. Thus, this marks the risk-based screening strategies could greatly enhance the screening effectiveness. So this is the micro-simulation model that has been framed, which has an intervention 1, which includes prevent initiation in new birth cohorts, cessation in current users. The second is screening of oral precancer, treatment of precancers at the early stage, surveillance of early stage cancers, and the third intervention is screening for early stage cancers and cancer treatment. These are the data sources that we have taken for intervention 1, 2, and 3, which will be discussed again. The focus of this white paper is to reduce the disease burden, to take up the effectiveness, that is to intervene in population and the number needed to intervene, to screen, to treat, to reduce the oral cancer or the deaths by oral cancer, to measure the program feasibility, to check the manpower that is required, and the main goal is to not just reduce but to eliminate oral cancer in India. Thank you. I think the data sources will be discussed by my colleague, Dr. Kirti.
Thanks, Shubha. So I'll come back to the, sorry. No, just go back to the same slide. Yeah, so previous slide. We'll come back to this. I think this is the key discussion. Anil, am I right? We need to focus on this. So before we go, sir, to the open discussion, we'll just look into the few of the data sources we have from GATS and the Kerala trial and IARC, and then we'll open the panel. So Kirti, yeah. So we have to come back to this later. Now close it as it is.
It's in edit mode.
Very good afternoon, one and all here. Today we are here to present the data source for the intervention 1 towards elimination of white paper. So the intervention 1 says cessation of habits. So towards intervention 1, the Global Adult Tobacco Survey India, which was conducted in year 2009-10, followed by 2016 and 17. As already, sir has already mentioned that there was a decrease in tobacco consumption already. So here is a small data that we were presenting about the tobacco burden or prevalence in India. So the percentage of adult tobacco users according to GATT survey 2016-17, they say around 29% are currently tobacco users, of which 71% are non-users. And among smokers, 10.97% of all adults are currently smoking, and smokeless, 21.4% are currently not smokers. And when we say together, men and women, it's around 28.6%. So prevalence of tobacco use and exposure to second-hand smoking. The prevalence of tobacco use when compared to 2009, and this is a comparison chart for 2009 and 2016. We can see that amongst the tobacco users, there is a reduction from 34.6 to 28.6, whereas smokers from 14 to 10.7, and smokeless tobacco 25.9 to 21.4%. The exposure to second-hand smoking, the various settings like home, workplace, government buildings, healthcare facilities, restaurants, public transports, again we can see there is a reduction in tobacco usage except for the workplace where there is a mild increase from 29.9 to 30.2. So, small data on the quit about, yeah, it's the same slide. So when about the quit attempts, data on the quit attempts, we can see the number of quit attempts in 2016 and 17 has increased compared to 9 and 10. While the health warning labels which are present on the cigarette packets, BD and smokeless tobacco is also increased, and the average monthly expenditure for cigarettes as well as BD, it is tremendously increased in year 2016 and 17 in spite of decrease in usage of tobacco. This is a data on state-wise prevalence of tobacco usage. We can see here the combined usage of tobacco, Goa being the lowest for 9.7%, and the highest is at Tripura, which is around 64.5%. So this is the state-wise prevalence of tobacco use, and this is a summary of GATT survey. Thank you.
We'll take discussion, or we'll just go to the other few. There are 6 more slides to discuss. Sir, Sir Pankaj sir and Gupta sir can take on this tobacco. So how do we move forward for this elimination? Go back to that.
Yeah, it's working.
Synopsis.
Oh, you're online?
Synopsis. Yeah.
Yeah, so Dr. Gupta will know that when Global Adult Tobacco Survey 2016-17 was being analyzed, actually we didn't have a lot of hopes because 2 years back Thailand GATS survey was released, and if you go to Thailand, actually theoretically they have done everything, all the check boxes they have done, and they did wonderful job. And when they did the second round of the Global Adult Tobacco Survey, actually the percentages increased, the consumption increased. So we were hoping that something similar will happen in India, but we were pleasantly surprised when we saw that there is a reduction in the consumption, overall consumption. But if you look at carefully, the bulk of the reduction actually happened in the less than 18 years of age. So 56% reduction was there in those teenagers and youth, and in adults, which was there. Now, if you ask me, having spent almost, Anil, you were saying graying of the hair from the black to white, think of my trauma, no hair. So, having worked 25 years almost in tobacco control, I realized that if you ask me one thing that India has to do, to not only reduce the burden of cancer, but also various health disorders and public disorder, is good primary education, which includes the health program. If you look at the Goa, go to that thing, and there is an example within India that how school health program can work. Goa, and we must remember Dr. Sharad Vaidya, who propounded this thing, that if we want to change the society, it has to come from the school. And he had an excellent school health program where tobacco control started from there, and then it went on to the adult, and then it became to the culture. So I think what you are asking me, that what can be done, I think school health program will not, primary education, including school health program, will not only reduce the burden of tobacco, but also many other etiological agents, but also many other things which are important for the society. So that is my short answer. Dr. Gupta, you want to say something?
Yes. Can you just help me with this?
Yeah, so few points.
I want to go for this cats.
One about the first sentence is one of the first slide that was shown. The word was elimination of tobacco and heavy alcohol drinking. Now the word heavy is completely superfluous. It should not be there at all. WHO also says that, and I have told in WHO meetings also, nobody agrees. That's a different matter. But here, if we are talking about elimination, it should not be heavy alcohol drinking. We all know that. Nobody drinks alcohol heavily. Nobody is a heavy alcohol drinker. Everybody drinks moderately for pleasure and for company and all that. So if you want to eliminate, it has to be only alcohol drinking, not heavy alcohol drinking. Second point about GATES 2, very good data, sure. But one thing that GATES 2 did, and GATES 1 did not, and that was after a lot of effort by me, and if I don't know if someone is also there, and Pankaj, of course, our focus on Areca nut. Okay. For the first time, GATES 2 collected information on the prevalence of Areca nut. Unfortunately, in their report, they have put the prevalence figures of Areca nut products that were used in the questionnaire, pan masala and those. So overall prevalence is there, but it does not provide use of exclusive Areca nut without tobacco. But it is possible to calculate from the primary data. I have done that, and it's very astonishing that if you eliminate all the tobacco users, even then the number of Areca nut users that is estimated in India comes out to be 10 crores. So the total exposure, we call about 267 or so million, 26 crores, 30%, 26 prevalence. If you include Areca nut exposure also as exposure to oral exposure to an oral carcinogen, that is something like 40% of the population is exposed to a carcinogen, oral carcinogen, directly in the oral cavity. And that shows the severity of the problem. point about school education, and Sharad Vedya, you referred, Pankaj, and even in the GATES one of the biggest surprise for everybody, not for just me, I mean even general public, was that the prevalence of smoking, prevalence of tobacco use was lowest in Goa. Goa, where drinking and Portuguese culture and all that was so prevalent, and first global tobacco survey prevalence was lowest in Goa. How did it happen? And Pankaj, of course, gave the answer, because the school health program started in Goa long back, and that probably carried out. And also, when we talk about program implementation and all that, but how we don't talk, and that's, I think we talked a little amongst ourselves, how the program is accepted by the population. You can have very good screening program, diagnose oral cancer, pre-cancer very early, give very good advice for treatment, but then if the advice is not taken by the person, it's of not great use. I mean, I was just remembering this, that in Andhra Pradesh, we did this oral cancer detection. We gave all facilities. If the cancer was detected, you go to hospital, we take care of it, hospital take care of it. But the patients did not go. I don't remember, we published a letter in Lancet on that. About 12 cancer we detected, I think about 7 or 8 did not go at all. And many of them came at midnight to the research team, huge oral cancer. So the issue is that at the population level, we don't understand investment in health. And that is true from at all level. One of the billionaires of India, he said that at the end, he invested well, became billionaire, but he did not invest in health. And that was a result. So I think we have to, when we talk of education, screening program and all that, we have to also make people understand that they need to understand and invest in health. Some investment in health in terms of, not in terms of money, but just in terms of thinking is very much necessary. And then only our elimination program and this screening program can achieve the results they need.
Sir, quickly when you're on the mic, your 1992 study is your cohort and the intervention harm. So, yeah, any thoughts on that, sir?
Yeah, this particular study, result of 20 years of work, one was first cohort in which there was no intervention was considered as control cohort, and the second cohort in which there was very active intervention with special films, documentaries we made, special posters, and the important parts were dentists were doing examination every year. And there were social scientists attached to that. So dentists would just say few words, social scientists would give more explanation. And the result of all that, there was a definite reduction in the tobacco use, and not only definite reduction in tobacco use, the incidence of oral pre-cancer was significantly lower in the intervention cohort. And among people who stopped their tobacco, there was no further development of oral pre-cancer. So, it shows that the intervention, education definitely work. Only we have to take it to the people and make it effective. And there was another study, this is from Bangalore, Ananta study, we were closely associated, talking about it, published a little later, but phenomenal result from this study. You can see that. And there was another study in Kerala where we trained basic health workers in 2 blocks of Ernakulam. Our dentists trained them, not for diagnosis, but just classifying people whether they need to go for further examination or not. And we had actually 2 types of training, one more intensive training for 1 week, one less intensive for 2 days. And they examined about 40,000 or so persons. And we published the result, very detailed results. What we found was that longer training, more intensive or less training didn't make a difference. What made difference was the health workers who did well in terms of more examination, did well in every aspect. Better diagnosis, better referral, better compliance. So, it's training that makes a difference. And they had no technology. They only used ice cream sticks. That's what we could get for oral examination. And very similar study, completely independently, was conducted around the same time, exactly same time, was conducted by, because our advisor was same, Professor Jens Sprindberg, was conducted by him in Sri Lanka. And when we compared result at the end, they were almost identical. Both are, of course, published, and of course, it resulted in a meeting on control on oral cancer in developing countries in Sri Lanka. So, the technology and methods and results and evidence, and now, of course, intervention trial from Trivandrum, of course, everybody is quoting, and those are very, very strong results. So all those are very much available, and what we need really is to go forward.
Thank you, sir. In the interest of time, Divya, you have 2 minutes to tell your school experience, and I think Professor Rajesh is interested to assist Varanasi, sir. Yes, no, sir? School program. Yeah. Divya, quickly, your challenges you had when you went to the school's tobacco cessation program. 2 minutes in the interest of time.
So there were lesser of challenges, but very motivating to go to schools at that time. So we have done on 2,500 children from 6 government schools and 6 private schools. The output and the feedback that we got from schools was very encouraging, especially from the students, because they understand that their peer group is using tobacco and they don't want to be part of that. So it's sort of a forced peer pressure to use tobacco, and in that case, when we did an oral cancer screening and sort of oral health checkup of all the school children, we realized that they are using tobacco, but they're not reporting it. So the self-reporting is not in concordance with their oral findings. So now we are working on getting the saliva collection and testing then for the nicotine and do further evaluation. That's
Thank you. So, Saman sir, your thoughts, your experience on tobacco cessation.
This is the most important aspect in primary prevention, both tobacco and weed liquid, including arecanut. And we have good evidence that if properly conducted with a multi-sectorial approach, that we can reach high-risk populations to cessation, activate cessation in these communities. And this is an important area where we have to put our effort. Of course, primary prevention, the effect will be seen only after 5 to 10 years, so we won't get an immediate result impact out of that. But for the future, that is the most important step we have to have, and that needs policy recommendations from the government, grassroots level implementation of public health workers actively contributing to cessation and educating them on the cessation methods in the field. Thank you.
Thank you, sir.
Now, can I just ask Anil about, with all this intervention effectiveness we have, that all the studies we have seen, right? From that, can you develop some kind of target, simulation to what is the target to achieve?
I guess I'll hold both. So if I understand your question accurately, Moni, it's about, can we benchmark a level of cessation and a level of prevention of uptake of the habits in future birth cohorts to say what would it take to achieve this elimination? Absolutely. I mean, I won't belabor the point, but the modeling exercise is the model. It has several components, and one of the first components is you first build a natural history study without any interventions, and then you come in and say, if my intervention is X%, what would be the impact, Y%, what would be the impact, and we would modulate it in such a way ultimately to say, to eliminate what are all the different components that have to work together, which component has the greatest bang for the buck, if I may, and what's feasible. So we could say what's a pie in the sky and what's actually feasible on the ground as well, certainly.
Thank you.
Professor Pradeep, yeah.
Thank you very much. Really, I think it's an ambitious but a very good direction. Just bringing my experience from the cervical cancer elimination, I was part of the global expert group set up by WHO. So I think there are certain differences, and I just want to highlight that. There were two very clear strategies in cervical cancer for which there was a lot of literature. One was the HPV DNA. There was a lot of literature on what should be the interval between the HPV DNA testing, and also a lot of follow-up on among women who underwent HPV DNA testing, that what were the cancer detection or at follow-up and different stages. So I think they used that for modeling. So that was the one thing they used. The second thing they used was actually the cohorts of girls who had undergone HPV vaccine. And the follow-up, there was follow-up data from some of the European countries where actually these girls had reached like in 20s and so on. And there was already evidence whether they were developing any, what we call as, the early stages cancer in context of cervical cancer. Now, I'm not sure, since I don't work in this area, whether we do have such robust data on 2 or 3 interventions which you think would eventually feed to elimination. So that was my first question. The second thing is that even the interventions for which data is there, and Dr. Partha repeatedly said that today, right? For the high-risk population, you just have one trial. And all the other data is not very conclusive. And the big question, and I know Dr. Prakash has worked on tobacco all his life, and we really look up to him. Most of the so-called smoking cessation data in India, I mean the tobacco cessation, is actually smoking cessation programs. Because even the government centers or wherever these studies were conducted, they were primarily doing smoking cessation and not smokeless tobacco cessation, and definitely not areca net cessation. So I feel there are research gaps for you to, I mean, you can do modeling, it's perfectly fine. You can model that what will be the effectiveness of various interventions and how they may add up to achieve certain level of reduction of incidence. But I feel there are research gaps. And I think this group could maybe in the next couple of months meet and go more deeper into what are those research gaps, and actually what kind of good research studies might be undertaken to answer those questions, so that when you do your estimates for elimination, you are able to use very robust sort of outcome data. Thank you.
So, ma'am, may I request you to take the lead on this? Somebody has to be.
If I could very quickly say, your points are very, very well taken. Being an epidemiologist, I'll be the first to say, repeat the quote of, all models are wrong, some are useful. And microsimulation model sits at the top of that pyramid. It's the poster child for assumptions. That said, we start with what we have. And part of the effort, as you rightly pointed out, is not just a modeling exercise. As you dig deeper, you'll understand the limits of interpretation of the data and the limitations of the data and the lack of data as well. So we have been planning on creating a triangle approach. You start with the modeling that will inform the research to happen. At the same time, we cannot just sit on our heels. We need to start demonstration projects with the tools that we have today. And to the point of cervical cancer, I would actually say, and I think some of you will agree with me, It is the exception to the rule, where you have a singular cause as a necessary cause, you have a vaccine, you have a screening modality that works perfectly, and that screening was introduced before any randomized studies were done. Pap smear, as you know, it's just the sheer reputation that led to reductions in cervical cancer incidence, and the treatment for precancers is quite effective. Yes, there's post-LEAP recurrence, but LEAP is fairly effective in treating the precancers as well. So it's a model, but it's the exception to the rule. For every other cancer, I think we are in the zone of oral cavity cancer. And again, your points are spot on and very well taken, but this is an effort. It's not a magic bullet. It's just the beginning of the sojourn. I'm sure others would have things to add.
Yeah, so just comment. So, sorry. Okay, I'll follow you. So the big difference between cervical cancer elimination and oral cancer elimination is that virus does not have a lobby. The biggest problem with oral cancer elimination is that we are faced with a very tough enemy where whatever research you will do, they will find gaps in it. Tobacco control, they will find gaps. Alcohol control, they will say no, moderation is good. Areca nut, no, it is in Hindu, culture, and there is Taiwanese areca nut usage is different from the Indian areca nut use. So I think the problem is that we are faced with a very tough, lobby. But the beauty of oral cancer is that if oral cancer cannot be eliminated, then this entire principles of screening and early detection should be removed from the book of epidemiology. The reason is that this is the only cancer where 90% is associated with an etiology. Number two, there is a distinct precancer phase which precedes cancer. There is a good treatment for precancer, and if treated, it can be cured. But what is most important is that it is so accessible for examination, for early detection. You have socially acceptable, financially viable tool for early detection, that is visual examination. Can't be anything cheaper than that. And the second, about the cessation. My biggest worry is that if you ask me, again 25 years I'm saying is spent, who is the most benefited by cessation? Industry. Industry is the biggest beneficiary of cessation, because while promoting tobacco or alcohol, they say that people could have quit. It is a choice for themselves. And we do know that tobacco is a one-way traffic. 3% of Indians are able to quit tobacco, that too after getting cancer and heart attack. Majority of the people, they are not able to quit, and that is why this entire facade of cessation has been created, and nicotine replacement therapy has been created by industry. And having 2 milligram of nicotine being available, actually, can you imagine who are the biggest manufacturer of nicotine replacement therapy? Tobacco industry themselves. So they gave point-to-point solution, right from the initiation to death, everything.
Thank you, sir. So in the interest of time, I think for the young people, you all understand the gap. I think I request you to raise your hand and see how you can come in for the solution. One last thing is, I'll ask Arshita to run through the screening data from Kerala trial, and one last word from everybody before we go to the next session. This paper has been discussed from morning, just to reiterate the numbers. Thank you.
Good afternoon all. I'm Dr. Harshita, faculty at KLE, Institute of Dental Science. So I'll quickly go through the intervention 2 and intervention 3 of the microsimulation model. taking the support of the Kerala trial study. So intervention 2. Yeah. So intervention 2 is basically focusing on the screening of oral pre-cancer. So Sankar Narayan sir's paper, it says that the totally of the intervention arm, the 96,000 individuals who were screened, there was a screen positive of 5,586 cases, of which the referral for all the 4 rounds were of 3,298. Of these, the healthy and benign, which were later filtered out, was about 770, that is 23%. And the OPMDs was 2,336. So over the 4 rounds, there were about 53 oral lichen planus, 898 homogeneous leukoplakia, 812 of non-homogeneous leukoplakia, and 573 of OSMF. The oral cancer initially which was detected, the screen positivity was 192, but over the 4 rounds there was addition of about 72 interval of carcinomas were detected over the 4 rounds. Coming to the third intervention, which is the screening and surveillance for early stage of oral cancer. So early stage being the stage 1 and stage 2. In the intervention arm, there were about 59 and 51, that is 21 and 18% of the early stage of oral cancer in the intervention arm. And in the control was about 10 and 9. About 31 and 35, which accounts to about 27%. And the cancer treatment, which is the third intervention, there was a totally reduction in the oral cancer mortality of 38%. And after 4 rounds, there was a significant reduction in mortality of about 79%. So this covers the intervention 2 and intervention 3 of the microsimulation model. Thank you.
Thank you, Arshita. Sir?
I think Partha mentioned about that we can screen any number of patients unless screen positives are followed up. It's when I think Pankaj knows about it. I was running a cancer center and so on. All these patients come to us. It's going to destroy the cancer center. Now we have young people here. So now if you look at the e-commerce, Amazon or Blinkit and so on, they found a way to solve the problem, logistic problem. This is purely logistic problem. Can we think about a logistic solution in an IT world? Any thoughts, comments? You mentioned about the grid, electric grid yesterday.
So about the logistical problem, I do not have any thoughts right away. But one of the things that you're looking for is something that can take the care to the patient, or to the participant, or to the person that has been screened. So maybe if we can come up with things that require not going to the hospital, but somehow a device going to the participant and then being brought back. So in a sense, bringing the Blinkit and others, but for healthcare in some sense, maybe that might help. So that's one thought. I'll come back a little. I don't want to change the topic, so maybe on the logistics, perhaps others might have some thoughts. I'll hand back the mic, but I'd like to take the mic to say a little bit about the education that you mentioned a little later.
Later, sir. I will just look at the online participants. And Saman sir, your final comments, please.
Can I say something on this?
So 1 second.
So,
yeah, Saman sir, please. So you're muted.
So we need to have a roadmap to take this forward, and I look forward to the next steps because we have made a lot of important decisions today, and these can be taken forward in a rapid way so that within a period of 5 to 10 years we can see the impact of the task force coming into effect. And there are several steps, including cessation, treatment of OPMDs, which is another aspect we need to discuss in the future, and also management of patients who are referred to cancer centers. Thank you.
Thank you, sir. We'll come back to you by mails. We need your guidance as we move forward.
Yeah, sure. I'm here to help you. Thank you.
Thank you, sir. Sir.
So I think what Dr. Kaur, you said about the disconnect between the community which is working on oral cancer control and actual groundwork. So it's a very pertinent question, and I think the most critical component of oral cancer elimination is going to be partnership from the dentist, who are in hundreds and thousands, who are so wary of biopsy. They also need a behavioral change, that biopsy saves lives rather than creates hurdles for them. The second is that they have to be empowered and trained to do not only biopsy but curative resections if the biopsy is positive. Third, they have to train themselves for opportunistic counseling and opportunistic cessation strategies. And last most important thing is that, like how healthcare workers incentivization has been done, it may be worthwhile doing a modeling where there is an incentive for every maxillofacial surgeon or a dentist to do a biopsy as well as curative resection. If this economics can be taken care, incentivization can be taken care, then it will be like Swiggy and Zomato, that people can order something. So I think with this, when we are talking about the scalability, Anil, it is very pertinent that we do not just screen and the aftermath is disastrous.
So thank you, sir. So now I'll go because of I think Kumar Prabha sir is waiting for the consensus document. Quickly, last word from all the experts. What should be our immediate next action plan? Sir, can you, sir, you can talk about the Varanasi.
Okay.
And
so maybe I'll quickly
yes, finish
speak about what you asked me to say about education. So I think the last 1.5 years we have been looking at building tools for screening, and I couldn't help feeling how weak and futile our efforts were in terms of doing the thing that needs to be done, which is elimination eventually. These are things that come down the stream, but we are not doing the prevention that needs to be done. But I also felt that there is an opportunity. The work that we had done for the last 1.5 years is something that was supported by the Ministry of Education. And this has actually opened up a window for us to interact with those in the ministry to see if evidences that we have on the field, particularly the one that I became aware of today, Goa, it's 20%. We have a team that's working in Goa. So if we can take that evidence and show it to the Ministry of Education, perhaps there can be a transformation in the curriculum to bring this to the schools in a much stronger way than it is right now. So perhaps there's an opportunity there. I just wanted to indicate.
Thank you, sir. So the next immediate action, what we have to do, one comment from everybody, and I'll wind up the session. So Moni sir, immediate next what for the elimination program?
I think the first thing is that we have to, it's very emotional for us to just start. But without planning, starting is a disaster. That will we all become depressed after some time. So I think we need people like Anil to guide and say, this is a target to achieve, realistic target. That needs to be defined first. And meanwhile, that each group needs to decide what are the gaps. For example, Dr. Kaur was talking about that. What are the gaps? And then we need to test it in different fields.
Okay. So, Pankaj sir, immediately what should we do? First, we have a synopsis now.
I think once we have come to this target, though it may appear lofty, but sometimes it is important to have such high targets. The first thing should be to have a buy-in from the Government of India, National Oral Health Plan. This entire effort has to be done as a part of the NOHP, where government takes this oral cancer task force and all the stakeholders to work alongside their own ambitious plan of eliminating oral cancer.
Thank you, sir. Gupta, sir.
Yeah, again, I would think that one of the first focus this group should have, the activity should be on Areca-nut, because the awareness level is so low, and the Areca-nut Growers Association in Karnataka has already written to the Ministry of Health and Family Welfare to discredit and reject the IARC evaluation, monograph evaluation of Areca-nut being carcinogenic. And Saman and I, we were the two who really, because IARC did not include Areca-nut as a substance to be evaluated, and they say we can't evaluate because this was not included, only betel quid was included. But I think our argument ultimately convinced, and they included and said that, okay, Areca-nut is also carcinogenic. And there is a great deal of pressure to not to accept that, and because of that, there is absolutely no policy as far as Areca-nut is concerned. Packages of Areca-nut do not say that Areca-nut causes cancer, even when there is a complete evidence and consensus on it among scientists. So I think this particular community, this particular group should put its power and its voice for Areca-nut control, Areca-nut elimination.
Thank you. Anil, last comment and then wind up. And anybody from audience want to add quickly? We are really running out of time because you have to start. And Dr. Neera, please come.
I'll just say I don't have anything profound to add than say we all need to huddle together and figure out the...
and you are the leader.
Immediate next steps.
So kindly lead, sir. Moni, sir. Yeah. Kunal, are you there? Kunal, you want to add something? Kunal Oswal?
So I think...
yeah, I'm there.
Just hold on for a second, please.
Yeah, standardized cancer awareness program, that not just in schools, but we should think of multi-pronged approach at the workplaces, in the schools, in the general population. There are a lot of women's groups. So I think standardized cancer awareness should be our first step, and then go ahead with the screening.
Thank you. Kunal, you are the last one to comment. Yeah, I'll give Kunal, there's one more Kunal Oswal on the online, and then I'll get to Kunal.
Yeah, thank you, Praveen. It was really enriching. I think we just need to put our act together, right from prevention, early detection to care continuum, and use each opportunity, each window, whether it's a dentist, integrated programs in primary healthcare, and keep challenging ourselves that working at tobacco, Areca-nut, start doing it.
Yeah. So
thank you, Praveen.
Thank you. And Kunal is from Bits Pilani, Goa. So he had steered our Goa program. Kunal, so Goa has got its due attention now.
Yeah.
Quickly, just 30 seconds.
Yeah, I think thanks all for all the inputs, and as a young researcher, this is very motivating. And about Goa, what I would like to say is there is focus on, in fact, I am part of some STEM education program. And if we can tie this to, STEM education and building awareness, I think already there is impetus to the middle school under NEP. There is already a lot of work happening on rethinking education in middle school level. So I think that there could be alignment, and we can get support from the local government.
Yeah, we would like to learn the Goa model.
Yeah.
So with this, thank you all for all the online participants. We are really running late. Yeah, we
should involve the YouTubers and influencers.
Yeah, noted. Okay, so thank you all for the online participants. You can still stay on. I call upon Dr. Neera to take the consensus document. Thank you all.
Good afternoon, everyone. I'm Dr. Neera Gupta. At the outset, I would want to thank each one of you, the organizing committee, Biocon Foundation, Dr. Anupma, Dr. Praveen, IISc committee members and OCTF members, all revered members sitting over here, Dr. Govind Babu sir, Dr. Chaturvedi sir, Dr. Vijay Chandru, Dr. Moni sir, and online presence of Dr. Kumar Prabhash sir. My apologies, sir, for keeping you waiting, but we are here to start now. You stay here. After this, you bring Dr. Kumar sir online. So, as we know, Oral Cancer Task Force had taken this noble initiative of building head and neck cancer Indian clinical practice consensus guideline. The very first guideline was published in 2019 in Indian Journal of Cancer, and then thereafter annual updates have been published in journal Cancer Research Statistics and Treatment. So, before I go there, I would want to invite Dr. Kumar Prabhash sir, that how it was conceptualized and how the journey has been for consensus guidelines, the first publication and updates thereon. Dr. Kumar sir, if you could kindly come in, please.
So, good afternoon, everyone. And at the outset, I'd like to thank OCTF for this opportunity. And as Dr. Neera suggested, it started in 2019 when this was one of the mandate by OCTF that we have OCTF head and neck cancer guideline, which is there. And what you can observe here that subsequently, initially when we missed a year, we have tried to see that every year this guideline is updated. Year 24 guideline has gone for publication, so that is also updated. And 25 after the discussion today, that will get updated again. And maybe this will be the only guideline, or maybe hardly anyone will be there from Indian context, where you have a guideline getting updated every year and published. And this was one of our mandate which we have tried to stick to it. Head and neck cancer, we don't have a lot of development every year, but yes, there are certain changes which happens every year, and this year also there are certain changes which has happened especially in nasopharyngeal cancer, and also especially in immunotherapy in other head and neck cancers where there are surgical candidates, and that part Dr. Neera will update. We will be including in the guideline, will circulate to all the members who have been part of the guideline, and once we have approval, we will be putting it for publication. And this goes for divided into 6 parts. One is overall head and neck cancer guideline, then all the subsites, and then advanced stage head and neck cancer guideline. So it comes into 6 parts which it is published. So over to Neera regarding updating the data which is there, which we will be incorporating, and we will be happy to take comments from the audience.
Thank you so much, sir, for setting the context. And as you rightly said, that 2024 update is in publication process. It has already been submitted. And now we are moving to progress with the 2025 update, the draft discussion that we are going to have now. So there are a couple of global updates on head and neck cancer, the new data that has come, and we look up to it that how it can be internalized to our Indian setting. So the first study that I would want to bring it to you is that radiotherapy plus nimotuzumab versus cisplatin in low-risk, loco-regionally advanced nasopharyngeal cancer who had favorable response to induction chemotherapy. This was a phase 3 randomized non-inferiority trial. Total number of patients were 381, low-risk LANPC. This study excluded the N3 disease and EGFR positive, and Epstein-Barr virus burden was less than 1,500 copies, and ECOG performance status 0 to 1. All patients received 2 cycles of paclitaxel, cisplatin, and fluorouracil induction chemotherapy. And then Arm A received nimotuzumab, and Arm B received cisplatin on days 1, 22, and 43. The 2-year PFS rate was nimotuzumab plus RT, 94.2% versus cisplatin RT, that was 95.8%. The findings of this study that showed that nimotuzumab plus RT represents an alternative concurrent treatment strategy for patients with low-risk LANPC with favorable response to induction chemotherapy. So this has been the part of recommendations already so far. So we moved, this was the additional data that was published this year. We move on to the another study. This is retrospective study, may not value as an evidence to put it into the recommendation, but however, it is something new that has been published, that is anti-programmed death 1 inhibitors, the immunotherapy and nimotuzumab in combination with induction chemotherapy for locally advanced nasopharyngeal cancer. This was retrospective propensity score matched analysis, total 150 patients that were included. The interesting part was that immunotherapy plus nimotuzumab INC and the CT, that showed the increased 3-year PFS rate, that was 96.6%, versus nimotuzumab chemotherapy alone, that was 79.8%. So for neoadjuvant therapy, the anti-PD-1 plus nimotuzumab, this was the first of its kind study from China, but of course this is retrospective, so maybe we need to generate more data in this setting and then look up to the recommendations. This is another new data which is there, that is omission of concurrent chemotherapy in and out of a phase 3 randomized controlled trial for stage 2 nasopharyngeal disease. There's a lot of publications that have come for nasopharyngeal cancer this year. And this was talking about IMRT alone vis-a-vis the nimotuzumab plus IMRT. And the data showed that stage 2 NPC early disease, IMRT alone can achieve comparable 3-year overall survival to concurrent chemoradiation while significantly reducing the side effects. So radiotherapy has been a standard of care, and this is reinforcement of what has already been there. So nothing, in addition, value addition to the existing recommendation. Now we move on to what is new. Immunotherapy we talk a lot about. This is tegitanlimab. This drug is approved in China for recurrent metastatic NPC in first-line setting. And for the first time, this data that reveals this was a phase 3 randomized 2:1 placebo-controlled trial. Total number of patients 295 and recurrent NPC disease. So tegitanlimab plus cisplatin plus gemcitabine versus gemcitabine alone, that was the control arm. And the PFS, if we look at, there was 53% reduction in the risk of disease progression when tegitanlimab was added to gemcitabine plus cisplatin. So this is something very encouraging, and addition of tegitanlimab to gemcitabine cisplatin enhances the progression-free survival, and median OS and PFS was not reached at this moment in time. So I open this up to the task force members, that what is your take, though this drug is not there, it is in China which has got the approval, should it be the part of the guidelines of 2025. Dr. Govind Babu sir, may I ask you first?
I think one study should not lead to a change or addition into the guidelines. So we need to wait. And as you mentioned, the drug is not yet available. In fact, there's another PD-L1 inhibitor which is from China again, but now in India. So we have data for that, and that has an FDA approval and the DCJ approval. Right. So maybe that would be better than putting this.
Yeah, so that is there already in the guideline, and we'll look up to more data. Dr. Kumar sir, your take? Dr. Kumar sir, are you there? He's on. Okay. So meanwhile, Dr. Chaturvedi sir, what is your take on that?
So I think we should be very clear that nasopharyngeal carcinoma is not a huge public health burden here. and certainly
Absolutely.
Northeast it is a problem. So if somebody has done a randomized control trial, certainly we can't repeat it here because the numbers are here small. So we have to rely on these RCTs, and therefore presently it is not available. I do not know who are the manufacturers, but certainly what Govind said, that there are good alternatives currently available, and presently there may not be a need for importing it as a, on compassionate ground.
Absolutely, absolutely. Thank you, very valuable insight. So let's move on to, we will definitely be circulating this to all the members to seek the majority of the inputs that come out with, but thank you so much for your opinion. Next we move on, this was an observational study, efficacy and safety of TP regimen doublet chemotherapy with triple oral metronomic chemotherapy, and in addition low dose nivolumab as an neoadjuvant therapy in locally advanced head and neck squamous cell carcinoma. So this year actually has been a paradigm shift in terms of neoadjuvant and adjuvant treatment, including the immunotherapy part of it. And here we are talking about low-dose immunotherapy. A lot of studies have been done at Tata with new low-dose nivolumab. And this is also one of them, which showed that the combination of TP chemotherapy with triple OMCT and low-dose nivolumab is highly efficacious and safe in neoadjuvant treatment. So far we were talking about the recurrent metastatic setting, but yes, it is a neoadjuvant setting. Kumar sir, are you there?
Yes, please
yes,
tell
sir.
me.
So your take on this study, it is a neoadjuvant low-dose nivolumab with OMCT and TP.
So what you suggested was right, and finally it looks like we are started getting evidences that things can move beyond what we have been doing as on date. That is only either surgery followed by CTRT or only CTRT as a treatment, and something we have been building around it. This is one of them, promising one. This is from CMC Vellore, and this is for borderline resectable oral cavity cancer. And this is one of the concept which was developed in our own country. This concept is not followed by and large across the globe. And this is a trial done at CMC Vellore, and they added immunotherapy to it, to the chemotherapy which is being given. And almost 20% patient had a complete pathological response. Now, this data we have not seen in the past in oral cavity cancer, that if you give treatment in our cohort where we had given chemotherapy alone, it was only 2 to 3% patient who had a complete pathological response. So that makes it exciting that this part of a treatment can be combined, because majority of these patients can go in a palliative treatment subsequently unless they go for surgery. So important that as many patients we can convert to surgery in this situation is important. So again, exciting data from CMC Vellore.
Thank you so much, sir. Very valuable inputs that you have given in terms of major pathological response and the PCR rates in this study. Thank you. And this is our own data, of course. We are so proud of it. So another two more important studies this year that have brought the shifting in terms of neoadjuvant and adjuvant treatment. And I would definitely want to hear from the group that whether we need to make them as a part of guidelines and add as an update to the existing guidelines. One is the neoadjuvant and adjuvant pembrolizumab in locally advanced head and neck cancer, Keynote 689 trial. 714 patients, those who received 2 cycles of neoadjuvant pembrolizumab and followed by 15 cycles of adjuvant pembrolizumab, in addition to the standard of care and standard of care alone versus that. So standard of care was surgery and adjuvant radiotherapy with or without cisplatin. And again, exciting results. Total population, irrespective of the CPS score, 57.6% that was the outcome in terms of event-free survival, vis-a-vis 46.4% in the control arm. So, sir, Govind Babu, sir, I'll come back to you. What is your take, whether it should be the part of the existing guideline update? Shall I give you the mic?
Yeah, this is good data. In fact, before this, there have been 2 other studies which have looked at this, and including looking at the pathological complete response. And they've looked at 1 dose of pembrolizumab versus 2 doses. With 1 dose, the pathological response was about 23%. But with 2 doses, it jumped up to 47%. So I think it is good that we include this as a part because the data is really exciting. And if in head and neck cancers you get a complete pathological response, I'm sure Pankaj will agree that their long-term survival is definitely better. Yeah.
Sure, sir. Moni, sir, your take.
See, this is one of the first time we are seeing this kind of exciting results.
Yeah.
But we have to be careful in reading the results. Okay. So the endpoint is progression-free survival. Okay. Not the overall survival. That's something we have to be careful. So now, in our setting with our financial restrictions control, we have to think about which population we have to use. I think I would focus on that borderline resectable setting. Yeah. That would be, dose can be decided at the induction level. Probably we may have to go to the full dose. We may have to. We don't have evidence for it.
Yeah. Chaturvedi, sir. Yeah.
So Dr. Lalit from Jaipur.
Yes,
I'm
sir,
also a
please.
medical oncologist in Jaipur. So the study sounds very good, very rational, but the Western world will never come with a reduced dose immunotherapy. So like Tata Hospital, Dr. Kumar, Dr. Pankaj and team have already documented that even 10% dose will be adequate. So if such thing comes in guidelines, then probably the usage and the economic burden will be higher. So these things can be based on choice or case-to-case basis. 1 year of pembrolizumab will be costing close to 70 lakh rupees as of now. And if the Indian companies start manufacturing, probably the price will go further down. But as of now, 70 lakh rupees looks too heavy, in fact, on most of our patients.
Yeah.
So it's a rational decision making by individuals, doctors and the patients will be better.
Yeah. Thank you, Shama, sir. And Dr. Chaturvedi, sir.
Lalit, I agree with you on the economics part, but we are talking about the science here. The guidelines doesn't mean you have to follow it. Guidelines means that you can leverage it, use it in the right patient that you have.
Absolutely. Dr. Chaturvedi, sir.
So here I agree with Moni on the aspect that ultimate test of any intervention is overall survival.
Yeah.
Now what happens, many of these early publications, because here if you read the whole paper, the study is still ongoing. And it is, they could go ahead because they had so many events and they could achieve the primary endpoint, so they went ahead and do that. I think we should wait for the long-term follow-up and see whether overall survival is different in the same population or not, because here again Prabhash and his group did the study where they found that only 3% of the patients who are eligible for immuno, they can afford it.
Yeah.
So affordability is a big issue, and final overall survival being the mantra is another thing. And what is other important is that there are other alternatives, and we are working on it. Very soon we'll be publishing our data. Perhaps this should be one of the hypothesis generating studies where in the maintenance phase, rather than giving the full dose, we give full dose in the induction setting, but in the adjuvant setting and in the follow-up setting, we should go to the low dose, so that we are making best use of immunotherapy, looking at the affordability as well.
Yeah.
Prabhash, what do you suggest?
Dr. Pankaj, totally agree with your comment, and this should be considered as an option, and which can be there as an option, knowing what kind of result it is. And clinicians, they have their choices, so they can make the choices. And what you suggested, I do agree. Both of us are aware the two things, and one, the result which soon will be will be in public domain for a very good a cheaper alternative shortly, and Dr. Pankaj will be declaring in few months down the line, which will be there. And second one, low dose immunotherapy protocol, our team at head and neck team at TMH and other centers have got together, and a study is running on that at this moment. Hopefully 2 years down the line, we will have that result also regarding if we do low dose, how the patient and the tumor behaves. That data also will be there. It will take some time, but the first part which I am more excited about, which Dr. Pankaj suggested, that, and in all probability, Dr. Pankaj, because that data will be out this year, because that is not in public domain, it is not included. That will also be included when we circulate to all the members for their consent for that alternative which will be available for our patients based on the data. And yes, mandate is there, and this is the mandate from TMH and TMC, and especially from Dr. Pankaj for developing cost-effective alternative. And what he suggested, some of those that start with full dose, go to low dose, increase more space. That certain concept, we are working on it, and hopefully we'll come back to people and OCTF to participate in those trials. Dr. Pankaj, is that okay? Summarizing this?
Dr. Chaturvedi said yes, very much. Thank you, Kumar sir and Dr. Chaturvedi sir, for your wonderful insights over here, and we look forward to that data to be incorporated in the upcoming updates of these guidelines. So while this is the last slide that I'm going to present, and while we are talking about cost-effective solutions to bring in, this is nivolumab data. This is not neoadjuvant and adjuvant. This is only adjuvant that we are talking about. And I think by next year, we'll have the biosimilars of nivolumab on the ground. And then I think this can apply very well to the current need of the hour for our Indian society. So this is NivoStop GOTEC 2018-01 trial, a phase 3 randomized trial of adjuvant nivolumab added to radiochemotherapy in patients with resected head and neck squamous cell carcinoma of high risk, those who are at high risk of relapse. 1:1 randomization, total number was 666, and arm A received the post-operative RT, cisplatin, and arm B received nivolumab with the standard of care of chemoradiotherapy. The median follow-up for this study was 30 months, and 3-year disease-free survival rates were 63.1% and Nivo plus CRT arm versus 52.5% in the control arm. So adjuvant nivolumab added to CRT after surgery provided a statistically and clinically meaningful DFS improvements in PD-L1 all-comers patients. This is the first time in over 2 decades that therapy demonstrated superiority over standard of care in resected LA HNCC in high-risk patients. Kumar sir, first to you, and then I'll go around the house.
So yes, what you suggested was right, that there is a positive study as far as the primary endpoint is concerned, and the previous and this study both will be criticized for OS not being the primary endpoint and OS data being immature. As much both of them looks like in the same direction, but yes, that criticism will be there for both of them. Regarding the previous drug, already FDA label is there. Most likely they will be part of various guidelines. And almost similar will be here. So it looks like these are the options which, these are those treatment which needs to be there as an option. I totally agree. We should always be careful about the cost part of it, that we need to have treatment which can be useful and affordable to most of our patients. We also do realize as the time has gone by, the cost keeps coming down for original molecule also. But what you told was right. In all probability, next year we will have biosimilar, more than one biosimilar in India, and that may make it more relevant. But yes, we also need to understand the limitation of these studies.
Yeah, thank you, Kumar sir. Dr. Govind Babu sir. So this can be added in the guideline update. Chaturvedi sir, do you agree? Moni sir, do you agree? Thank you. Dr. Vijay Chandru sir, any comments from your side? Thank you. So with this, I think we come to an end of this discussion. The draft will be circulated to all the members and those who have been part of this consensus guideline update. Do we have Dr. Sumit Goyal online? I think he said that he'll be present online. Anybody else? What's the name? Dr. Abhishek Mahajan, can you hear me?
Yeah, I can hear you. I just wanted to update, there's another update on radiological extranodal extension on the imaging in nasopharyngeal CA. So I think that should be, assessment of extranodal extension should be included in imaging so that the audience is aware of what's external extension, how important it is. So we can do a small paper on external extension.
So, yeah. So it was radiological extranodal extension you were referring to?
Yeah.
Yeah.
Yeah, radiological.
Okay.
This now included for nasopharyngeal, but soon it will be included for other cancers as well. So I think it's important that the audience is aware of it.
Sure. So that we'll take care, and we'll make sure that it is made part of the updates. Thank you, Dr. Abhishek, for being present. Anybody else online? No? Okay. So Kumar sir, final word from your side, and then we close.
So thank you so much. No, I think so. We'll make the changes. We'll circulate to everyone, all the members, as we have done in the past, and then hopefully we have been a bit late every year. Hopefully this year we will be on time, and hopefully next year we will ensure that every year in the beginning we have this guideline. Thank you so much for all the support, Dr. Neera.
Thank you, sir. Once again, all the Oral Cancer Task Force member, thank you so much for being so supportive in this initiative and all your valuable inputs that you continue to support with. Thank you, and have a great day, all of you. Thank you, organizers.
Thank you.
I request everyone to assemble downstairs for a group photograph, followed by lunch at main guest house, a short walk from here. For your convenience, gaps are arranged. Kindly utilize the service to reach the dining area. We'll resume the session at 2:30. Yes, first photograph.
Hey, Manoj. यहाँ पर नहीं पड़ा है लास्ट में ओनली 2 स्पीकर्स आते हैं डॉक्टर वर्चुअल फिर इसे ऑनलाइन देना पड़ेगा मैम कहाँ है ओके वेट हाँ ओके
2 o'clock ಬರ್ತೀವಿ 2 o'clock ರೆಡಿ ಮಾಡ್ರ ಬಜೆಟ್ ಡ್ರಾಪ್ ಮಾಡ್ದ ಪ್ಲೀಸ್ ಸರ್
ಹಾಂ ಊಟ ಆಯ್ತಾ ಇಲ್ವಾ ಈಗ ನಿಮ್ಮದು?
Yeah, yes ma'am, I can hear you. Hello, test. Wait, ma'am. Hello, check. I have put it in my.
You are put it.
Yeah. Just keep it and rest.
Today morning I sent.
Yeah.
I'll remote?
Yeah, mine first.
No, this one. That is for the.
Yeah, pointer. Yeah, I'll check. Check. मीटिंग किसी ने खत्म कर दिया क्या? खत्म कर दिया मीटिंग। तो कभी ज्वाइन कर दो। मेरे पास नहीं है पेन ड्राइव, मैं नहीं दूंगा। मैम से बात कीजिएगा। गौरी मिश्रा, राइट? इसको 1 kg ऑल्ट F4 यूज़ का स्क्रीन शेयर कर दूँ
Welcome back. We now move forward to our next session on implementation research and health economics. This session is chaired by Dr. Ganesh Kumar, ICMR, National Institute of Epidemiology, Chennai. I now invite Sir to lead the session.
Thank you very much. Good afternoon, everyone. Having heard about all the interventions, innovations since the morning, now we are moving towards the most important piece of that, which is real-world implementation. And we have two extremely good speakers. I will introduce the first speaker, who is Dr. Gauravi Mishra. Dr. Gauravi Mishra is a professor and a physician in the Department of Preventive Oncology and also the Deputy Director, Center for Cancer Epidemiology from Tata Memorial Hospital, Mumbai. She will give us a kind of like a fantastic gist about the real-world implementation of especially the oral cancer screening. And we'll keep discussing more about that. Welcome, Dr. Gaurav Mishra.
Good afternoon, everyone. I thank the organizers and especially Dr. Prati for having me here. And so what I'm going to come is back from the high-tech AI-based, what I learned yesterday a lot from the real-world implementation. Actually, my earlier career started with doing a lot of huge randomized control trial, but now I want to move towards the implementation science, and that's what I'll be talking about. So I'll not talk about one particular trial, but just give you an overview of different types of implementation that we have undertaken. I like to work in the workplace settings. especially because if you have a good rapport and if you're nicely associated with the main stakeholders, that is the management and the union, if you're assured of their support, then you are assured of good follow-up. And for any program, follow-up is the key, especially when you're talking about tobacco cessation, when you're talking about cancer screening. If you don't get back the referred patients, and if you don't get good follow-up for tobacco cessation, then the program fails. So workplace, I feel, is a very good setting to work with. And many a times we talk about NP-NCD program, and we give the entire burden of implementation to the government, that government should implement. But I think it needs to be a multi-sectoral and hand-to-hand. We need to coordinate, cooperate with the government and look at how it can be implemented in different ways. And I will also talk about what we are doing in the community settings in the real world situation. So this program I have just completed, so I can talk about it. This is about implementation of the entire NCD program in the police personnel. Again, you know, working with the police is not so easy. You need to have permissions from the highest authorities. And when you're talking about high-risk screening, it really is important, and it is considered to be an appropriate approach, interventional approach, just because it adds lots of cost effectiveness to the program and increases the program efficiency. Now, why this police workforce? We all know that police people, they are highly stressed, and they have very odd sleep-wake patterns. They have high addictions to tobacco and alcohol. And then the dietary patterns are also very odd. You will see in Mumbai, people just going and eating a vada pav and surviving on it. So, and I was really surprised when I started working with this force that they only have one examination at the time of recruitment. Thereafter, there is no annual checkup or something like that. And then directly when they develop a disease, they go to the medical center. Though they have, especially in Mumbai, they have the dispensaries spread all over, but that is for a curative purpose, not for a preventive purpose. And there, of course, they have all the empaneled hospital all over Maharashtra also, and same would be in other states. So a few efforts are actually made towards prevention and early detection, and we got the IC approval for this. So initially we had planned this program for Mumbai city. We thought we'll cover the entire Mumbai police in 3 years. But then we wanted to show that it's a replicable model. So we replicated it in 3 districts around Mumbai, Thane, Mira Bhayandar, and Navi Mumbai. We also included traffic police, railway police, Maharashtra State Security Force, and the State Reserve Security Forces. So the idea was not just to implement the program. The idea was to make it a demonstrable program. The idea was to make it a replicable program and also a sustainable program. That it shouldn't happen that 3 years we work on it and, you know, we close the project and it doesn't continue any further. So we wanted to make it a sustainable program. And you can imagine such a sensitive group to enter this workforce, you really need to have permissions from the highest authority. So you can see here the police commissioner, the then police commissioner, Sanjay Barveji, he's inaugurating the program, and our director, then director Dr. Badve is here in the program inauguration, and this inauguration is being held at the Mumbai police headquarters. So that was the time that we really came to know that there are so many regions. They are divided into different regions and different zones, and under each zone there are so many police stations. So you can see here all this 92 police stations in different regions, and we actually went there and held camp in each and every police station for a week or 2 weeks, depending on the workforce that was present over there. And we then, when we replicated, we had to understand the divisions of all these different police also, how are they distributed, where they are placed, so that we could go. When you're planning such a big program, it really needs to be pre-planned properly, and you need to have not just permission from the police commissioner, but you need to take into confidence the DCPs of each zone and the senior police inspector of each and every police station, so that they also cooperate in a good manner and they understand the importance of the program. So entire program was planned, and then imagine obtaining list of police people from each and every division. Again, this is a very sensitive information, but then we were able to obtain the list of police personnel in each and every police station. Just on a lighter note, when we started a program, I was interacting with one of the DCPs, and She was really kind, and she was very committed for this, for early cancer detection. And whenever I used to call her, she used to say, I'm so scared to receive your call because you ask me the crime rate, I will tell you. You ask me all this, information. But when you ask me information, how many police are there in Mumbai, how many police are there in Maharashtra, we don't have any such record. So we actually had to go to each zone and each police station to obtain the list, and then we had a comprehensive list. So any community-based or outreach program requires a lot of staff, and we recruited this staff. We trained them thoroughly into different activities that they were supposed to do. Because the time is limited, I'm not describing the entire program, but this is the methodology that we went through. That in every police station, we actually had a small inauguration program so that everyone was sensitized as to what we will be doing. Then we registered, we called every police personnel, we registered them, and they signed an informed consent form after understanding the program. We conducted their personal interviews in order to have a risk factor assessment, and then delivered a very standardized health education program, explaining them the risk factors, signs and symptoms, methods of early detection, prevention, what kind of screening we'll undertake. All this was explained to them. And we do not undertake any screening program before being preceded by a thorough health education program. We were screening for NCDs also. So we recorded the health, height, weight, blood pressure. The blood was collected for glycosylated hemoglobin. Otherwise, normally in our NP-NCD, they do the random blood sugar, which really doesn't carry much weightage. And then we screened them by oral visual inspection at the police station for all of them. And women who are above 30 years, we screened them for breast and cervical cancers. I will just present the oral cancer findings today. This was a tobacco cessation clinic. So we never ever miss an opportunity of undertaking the first session of tobacco cessation counseling whenever we are doing an oral cavity screening. Because there, the participant is in front of you. So it will be a lost opportunity if you don't speak on tobacco cessation. So the first session was conducted at the police station. We referred these people to our tobacco cessation clinic at the Tata Memorial Hospital, all those who were tobacco users. But as you can understand, the compliance there was very less because they did not want to come just for a TCC clinic. So most of the tobacco cessation counseling follow-ups we actually did telephonically. All those who were screened positive for oral cavity cancers, we referred them to Tata Memorial Hospital for further investigations and diagnostic workup. And then those who were, they were screened positive for other NCDs like diabetes, hypertension, they were referred to their police hospital, which is at Nagpada. We wanted to make this a sustainable activity. So what we did was we understood that they have the health structure in place. They have the health system in place wherein there are dispensaries in different areas of Mumbai. And they also have two hospitals. One is at Parel and one is at Baikala. So we invited all these medical officers and the nursing staff for different CMEs on different topics related to NCD. And this was done throughout the year. In addition, what we did was whenever we were conducting any camp in the police station or in the police colonies, we did for some family members also, we invited the health staff over there to have a hands-on training. So we wanted to have completely a sustainable model that they could take it forward. Now, a bit of findings that I would like to share. The 35% of the male police personnel were tobacco users, and 40% of them were using alcohol. So it is important to note here that 24% were using both tobacco and alcohol, which is really a risk factor for oral cavity cancers. Among women, the tobacco use was much lesser, 4%. And among women, it was mainly in the smokeless form. Very few were smoking. Whereas in male police, 15% of them were using smoking form. And there were another 10% who were using both smoking as well as smokeless forms. Now, the gist of the entire work that we carried out over a period of 5 years, including all the different districts that we did. So we covered 55,000 police personnel, and that is the data I'm presenting here. In addition, actually, we did 6,000 family members also. Amongst this 55,000, those who were enrolled, all of them actually participated in the health education program. And our health education program is really very effective that all of them complied for oral cavity screening. And when it comes to oral cavity screening, actually people participate very easily. Whereas when it comes to breast or cervical cancer screening, there is still hesitation if there is if they are worried about, privacy and other things. So 5% was our screen positivity rate, and 75% of them whom we referred for further diagnostic workup actually came for the further diagnostic workup. And I think that's the strength, that compliance to the referral was good. Of course, we all would like to have 100% compliance, but that's really not something that's achieved in a real world setting. Now imagine this 1,800 people, okay, they totally asymptomatic. Had we not gone there, they would have never come to us. They were happy in their own settings. 1,800 people detected with oral precancers, and 23 of them detected with frank cancers. I mean, there's something in your mouth, you can open your oral cavity and see it, right? Or it must be troubling them in some way or the other. But only because of this program they were diagnosed, otherwise they were very happy in their own setting. So this is the outcome of the 5 years of work that we did among the police personnel. So I would like to say that the present study demonstrated, because I have not yet presented the hypertension diabetes findings, but it reflected really high morbidity and mortality among police personnel. And we think that, more important is the preventive and the promotive health and not just the curative one. We are now presenting these findings to different police commissioners and telling them what action points could be taken. For, again, on a lighter note, when we went to the Nagpada Police Hospital, and we were looking at compliance is so low when we are referring them for diabetes or hypertension. And when I was personally visiting them, I understood that there are no full-time MD physicians out there. There is just one medical officer and a CMO, and all others are honorary doctors who actually come there only to have a police eye card. So they just visit, once in a week or twice in a week for 10-15 minutes, half an hour, and they go. And they were so upset that now there were 50 people sitting outside the OPD for to get further diagnostic workup. So we still have to publish our main paper. So just taking from there, we have worked in different workplaces and giving them thorough health education and oral cavity screening. This is all incorporated and very easy to undertake in the workplace setting. Again, one of the programs that, this is quite an old program that we took in a small size industry with just 100 or 104 employees. But this was a very intense program because the number of employees were less. We could follow them up every 6 weekly. And we noted the history, examined the oral cavity, and we had this focus group discussions every 6 weekly, so that among the tobacco users, so that helping them to quit tobacco. We also had some sessions for the contract employees who were low on educational level, and for the family members of the employees. So now there was, we telling them that you give up tobacco, and now there were family members also putting pressure that no, you need to quit tobacco, because we had also had education for them. And we did urine continent test at the end of 1 year to really assess whether self-report history matches with the history that with the chemical findings. And those who had quit tobacco, we gave them a pin saying that you are a proud tobacco quitter. So 48% of the employees were using tobacco when we started the study. 40% quit at the end of 1 year, and 40% of them had oral precancerous lesions among those who were using tobacco. So again, I think it's important that we work in the workplaces, and we have published several papers. Again, another high-risk group, auto rickshaw drivers, and if you go anywhere across India, you will see they chewing tobacco and spitting. So we had some program for them also. And the cab drivers. So in 2010, we had this law saying that all the cabs should be made smoke-free. And overnight, they were told to put stickers on all the cabs, that if they don't see a sticker on the cab, they would be fined 200 rupees. But then what about the cab drivers who were so addicted to tobacco? And we had to do something to help them quit. So we undertook this IRB-approved study to understand what was their reaction to prohibition of smoking in public place, and we wanted to see their oral cavity. So after getting IRB approval, this was for 400 cab drivers, we went to different cab driver stand, and the entire health education was conducted at the stands, and we had a van wherein we did the oral cavity screening, and then follow-up was also done at the cab driver stand. So totally 400 cab drivers were there, and 64% of them were using tobacco. If we look at the findings, there were 112 cab drivers who were diagnosed with oral precancers, and 1 cab driver had frank oral cavity cancer. So this is the prevalence, the kind of prevalence that you see amongst this high-risk group. And then we, of course, published several papers saying this. Then BEST, I don't know the bus drivers over here, but in Mumbai, BEST is our lifeline. The 42,000 employees are employed in the BEST corporation. They run 11,000 buses every day and more than 35 lakh commuters every day. So they are our lifeline. And you will see, Dr. Gupta will agree with me, that there used to be all pan masala ads on the buses. So we thought, let's work with them, because again, in 2010, this law had come, but in fact, most of the drivers and conductors were using tobaccos, especially in the smokeless forms. So again, we had lots of meetings with the management, with the union, and again, the chief medical officer of BEST. And we conducted this program amongst 4,000 BEST drivers and conductors. This was held at their depots. So we went in their depots, registered them, had personal interviews, conducted the screening, and then again, to make it sustainable model, we conducted a lot of CME programs for them, for the medical officers and the nursing staff, so that they could take this program forward. And so 43% of them were using tobacco, and we got a quit rate of nearly 66%. This was again with a lot of follow-ups. Simple oral visual inspection, we could detect 494 cases of oral precancers and 1 case of frank oral cavity cancer. Again, this is published. Call centers, when you're talking about BPOs, we can see all youngsters there using tobacco. And again, use of smoking tobacco is really not uncommon here. Even women, females using tobacco is very common in this industry. And we had a randomized control trial to see how we could help them quit tobacco. So we have worked in a lot of government settings where we went, gave health education. We conducted screening out there, like sales tax employees, different engineering industries. And we do a lot of work with the schools also. And when we are doing health education in the school, it is not in the form of lectures, it's engaging them, making them write essays, drawing competitions, slogan competition, etc., so that they are engaged in what we are talking. So lastly, I would like to share this program that we just completed in the community settings of Mumbai, wherein Mumbai is divided into 25 wards. So what we did was, from each ward, we recruited 1,000 people who are high risk, that is either using tobacco or alcohol or both. And we wanted to have the risk factor assessment, create awareness, and screen them for oral cavity cancers, and follow up them for diagnostic investigations and completion of treatment. So when we are working in the slums of Mumbai, it's really a congested area. And we obtained some information, had meetings with the BMC so that they won't object when we are in the area. And we have to have good rapport with the local leaders. So whichever party it is, it doesn't matter to us. They are all our stakeholders. We went door to door. We inquired about tobacco, alcohol habits, and enrolled the eligible population. We then registered that at the camp place and obtained informed consent. And thereafter, you can see in many areas, like especially M ward, Dr. Gupta would know, this is all Mankur area, wherein we did not get any camp place. Normally what we do is, anything that is available in the area, it may be a Shiv Sena office, it may be a temple, Gurudwara, Anganwadi, Balwadi, school. We get some place to conduct our camps, but here in this area, you can see that we are doing the health awareness on the streets. And for oral cavity health education, it's really not a problem to do it anywhere. And then we conducted screening for them. And those who were screened positive, we referred them to Tata Memorial Hospital, wherein they undertook further diagnostic investigations. So also using a bit of technology, we had this dashboard. We were entering our data in the field on tablets. And at any given point of time, I knew that from each ward, how many are recruited, how many have been screened, how many are screened positive in a month, how many screenings are being taking place, how many have been referred but not yet attended hospital. And this really helped in monitoring and knowing where to focus attention. So we screened around 25,000 people. and you can see that the participation in screening after the health education session was nearly 100%. Again, this shows that effective health education, and you can really increase the screening rates. 7% of them were screened positive, and more than nearly 82%, 83% completed all the diagnostic investigations. Again, look at the benefit that 1,500 people diagnosed with oral precancers, and 18 of them diagnosed with frank oral cavity cancer. Sometimes it just sounds unbelievable that they have something in their oral cavity and they are just at peace. Just because we went there, they were diagnosed. Many cases of submucous fibrosis, this was the highest, followed by leukoplakia. So what we did was we captured all these images and we converted that into an atlas so that, you know, we can train the primary health workers using these pictures. And we released this on the World Cancer Day in February. And recently what we did just 2 days back, we converted the entire methodology into a demonstration project so that it will help others to implement it. If that we have gone through such and such methodology and this is the kind of compliance you can get if you follow it. So we converted that into a booklet and we have released that just 2 days back for the occasion of World Head and Neck Cancer Day. A little bit of talk on the innovations. We also, when we are talking about standardized health education program, we cannot go everywhere and deliver it. So what we have done is, in collaboration with IIT Mumbai, we developed video-based tutorials which are animated, which help us to give standardized health awareness talks, and they have a lot of videos inside it. So it helps them show that how exactly the oral cavity is to be examined, and we have it in 3 languages: Marathi, Hindi, and English, and we can always translate it into more languages. And we evaluated again this video-based tutorials. We have published a lot of training modules so as to help capacity building of the government public health services staff. And then when you're talking about school children, we need to really speak in their language. And we had a volunteer who was very good in art, and he was with me right from 9th standard. Every vacation he used to come and sit as an observer. So he made, we got this, flip charts done from him, which we use in school for health education. And as someone had rightly pointed out, in Maharashtra, a lot of women use masheri. And women who are in media houses, call center, they do smoking also. So this was specifically, we have created a flip chart directing education specifically towards females. We of course have a lot of self-help material also that we have developed. Lastly, how do we integrate with the government? We have started an IRB approved trial with the Mumbai Municipal Corporation. This is a very ambitious trial that I have taken up, wherein we are going to train all their 6,000 paramedical staff in first year just delivering standardized awareness program. And from second year onwards, we'll help them setting up their awareness and screening clinic in their own health post. So we will handhold them over a period of 5 years and also help them setting up tobacco cessation clinics. So this program was again inaugurated on the World Cancer Day by our director. So just to summarize, I feel that giving a standardized cancer awareness talk, I mean, anywhere and everyone can do it. And also oral cavity screening, whether you are in a dispensary, in your own clinic, whether you are in a public health setup, you are a dentist, doctor, anyone can do it, and we should not miss this opportunity. You really can detect so many cases of oral precancers and cancers, and don't miss to combine tobacco cessation advice with it. So I feel that a lot of places we have established demonstrable model, and we are seeing to it that it becomes replicable and also sustainable. Thank you.
Thank you, Dr. Gauravi Mishra. There are fantastic observations. Number one, it's an worksite intervention where we're trying to detect cancers there. From your data, I observed that in order to detect, that's called yield, we say in epidemiology, is that like if you screen 54,000 people, you can identify 1,829, which is 3% is the yield. And in terms of detecting cancer, if you screen 2,500 people, you can detect 1 case of cancer. That is the amount of efforts which all it will take. Very impressive work in multiple settings, and of course in the next session we'll be going to talk about a lot of challenges, but I'm going to restrict 2 questions for the interest of the time. Yes.
Thank you. Yesterday we were all talking about finding more men. I think you've gone to the workforce to find more men. We got half our answer here. But I think one of the studies, among the last studies that you showed, there were 1,000 men and 4,000 women, even when you went to households. How did that happen?
Yeah, 2 reasons for it. One is that many more men were tobacco users in that community. And coming to yesterday's question, normally what we do is, if we want to have males also in the study, we go in the evenings. So we go early mornings or we go in the evenings. We direct our efforts on the Sundays and holidays. So that is how we try to get more.
So I think there's just a second part to that question. When you say we, it's TMH staff, or was it also the primary health work? I mean, from the primary health centers?
So many of these studies, they involved our project staff we employ, but we try to also get the staff, especially when you are working in the rural areas, we try to involve the ASHAs and ANMs also in our efforts. In the police project, we try to involve the paramedical staff of the police, so that mainly because they should get hands-on training when we are doing it.
Okay, so I think I will take up the next question, and I'm going to close that question session. The question is from my side, still in an hierarchical organized sector, police sector, there is some around 30% is the dropout, which we have observed. Those who are screened positive coming for the confirmation. There will be possible reasons. If you want to quote, you can quote one. But however, we are going to have a detailed discussion in our next panel on that.
Police, I mean, we are all overworked, we know, but then police, I can't tell you the level of, they are working overnight, and then you tell them to come in the morning directly from there. That's their only off day, perhaps in the last 15 days. And sitting there, they used to doze off. So it was really difficult for us to get them. And again, you can't imagine the kind of fear. We talk about fear of cancer. We are located at Parel, and just a stone throw away is the Naigaon police station. And in fact, for everything they keep coming to us for everything. But when they were referred, in fact, one police person, he came to my cabin and he told me, just because you came again and again there and you told my senior he has to come, that's why I've come here. But if you examine me, I know I'll be detected with cancer because my father died of cancer. And I'll go outside, and from this 3rd floor, I'm going to jump down if you examine me. So I said, you please go back, So that fear of being diagnosed with cancer is also so high, even amongst the police whom we think they are fearless.
I can't agree more. I had a 1-hour conversation with a cab driver in Mumbai who was chewing gutka. I was asking him about that, what makes you to chew this gutka, what excites you? See, if I work for 24 hours, I get 1,000 rupees. And for 24 hours to keep me awake and vigilant, gutka helps me. That's a simple fact, whether we accept it or not. But that's what his perspective is that. We can still discuss. We'll move to the next session. Thank you, Dr. Gaurav Mishra. Give her a great hand. We have our next speaker who has joined online, Professor Rama Baru. She was a former professor of Center of Social Medicine and Community Health, Jawaharlal Nehru University. Yeah. Yes. Yeah. Professor Rama Baru, are you there online?
Yes, I'm here. I'd sent my slides, and if that can be loaded.
Yes.
Thank you. Before the slides are being prepared, I want to thank the organizers and especially Dr. Prabdeep Kaur for extending this invitation. I was very, very impressed with Dr. Mishra's presentation because I'm basically a social scientist by training, and I like to take a systems perspective to many of the issues that she raised, and her work is really creative and commendable. So what I'm going to do is really look at cancer, and especially oral cancer, from the perspective of social suffering. And this is not just a layperson term, it is a term that has been very consciously worked on by social scientists to say that social suffering is really applicable to understanding the kinds of issues that people who are diagnosed with any condition, which is especially chronic, have to face. And in here, we are not just talking about the individual.
Professor Rama, sorry to interrupt. Whether the slides are visible?
Yeah, the slides are visible.
You can
Thank you very
give us
much.
that if you want to advance the slides, we can do it from here.
Thank you so much.
Thank you.
So as I was saying, that the physical pain of a person diagnosed with cancer is very well acknowledged and known. But the issue really here is to go beyond the physical pain, which is also suffering, and to look at the kind of disruptions. And here we are using the term disruptions specifically in relation to what does it do to the different aspects of everyday living. And here we are really looking at what are the socioeconomic consequences. So one of the methodologies that are really useful, but very few studies have actually acknowledged or written about, is the lived experiences of individuals who suffer from cancer. And how do we understand it? We have to understand it as being embedded in a network of social and economic relationships. So I know there are a lot of health economists who do a lot of cost-effective, cost-benefit kind of analysis. But here what we are trying to really say is that when an individual suffers from a particular disease, and in this case cancer, this pain and suffering gets extended out into disrupting the network of social and economic relationships that he or she has been used to. And the disruption of these relationships is one for the individual themselves, but it also affects the caregivers in the family itself, and the community at large. So we find that there is a lot of quantitative and qualitative evidence on access to health services, expenditure involved, and lived experience of coping with cancer. But if you actually do a good systematic review, you'll find that in the Indian context, there is very little. So what I'm going to really present is some of these some of these studies that have given us some insight into the complexity of the problem. So one of the things you find is there is a great deal of scholarship which focuses on the clinical dimension. So of course the biology of it, the diagnostics, the medicine part of it, but also the prevention and treatment of cancers. So there is this body of literature which is available and all of you are familiar with. Then there is another very important area, which is the availability, accessibility, affordability, and acceptability of health services. And these are the 4 A's. And I think Dr. Mishra's presentation spoke a great deal about how do you bring about acceptability. So you can have like a Tata Memorial Hospital very next to your a place of work, but you may never actually go there for a number of reasons, which of course raises many issues about how you need to have continuing education and building the trust of communities and families to be able to access these services. Actually, very little attention is paid to everyday experience of patients and caregivers. And I think this is a huge research gap in chronic disease per se and cancers in particular. And there are very good recent studies on accessibility and affordability using largely the NSSO data, and it demonstrates stark socioeconomic inequities. So this becomes a very important aspect. When you say socioeconomic inequities, we are looking at multiple axes of this. So we find interstate variations in terms of availability of services, accessibility of services, and also the cost of services. Then we find there is much variation across income, caste, and gender. And these become very important in actually determining the problems in availability, accessibility, and affordability. And the acceptability part of the story has a lot to do with the behavior of health systems itself, the behavior of the human resources part of it, how well you communicate, how well you build trust, etc. And the very important aspect in the Indian context today is there is a social gradient in inequities. So you have upper income quintiles, a very large middle income quintile, and the lower income quintiles. And I've just given a reference to work done very recently based on the National Sample Survey. And if those of you are interested can read around that. I'm going to present some of their key findings, and I think these are interesting. One is the intensity of healthcare utilized in terms of length of hospital stay, medicine, and diagnostic tests for cancer outweighs all other major diseases. So you immediately find that this particular disease has a very serious impact on the individual and families. And it also shows us that there is very high out-of-pocket expenditure for treatment of cancers, given the long duration, the follow-up, and the intensity of hospitalization that is required depending on when the particular condition is diagnosed. And for poorer households, especially lower income quintiles and SC/ST population, they find that they make fewer inpatient visits, there's weak uptake of medicines and diagnostics, mainly due to financial reasons. So you even have people who start a treatment or they're diagnosed with a disease and then they fall out of treatment simply because they are not able to meet the financial requirement to do so. And there is also evidence in this survey data which shows that they are borrowing very heavily to meet treatment costs, and the indebtedness due to the illness becomes a burden for households. Next, please. So what is interesting, I think, is that while the poor really suffer the most, the middle income quintiles are not devoid of this kind of suffering, because across income quintiles, there's higher incidence of borrowing and selling of assets, loss of livelihood, loss of income, lower work participation rate of family members. Now, this is an aspect that is never really acknowledged. But when women become caregivers, they come out of the workforce. They try to readjust and recalibrate in order to become caregivers. And there is also a rationing of resources within the family, whether it is for food, whether it is for education of children, whether it is for access to health services for other family members. So this particular aspect it brings out the complexity of the disruptions. One of the very important aspects that this survey data shows up is that there is a weakness of primary level services for screening, early diagnosis, which actually results in detection of diseases at a later stage, and then it requires tertiary intervention. This is a cost burden for the patient and their families, as also for the health service system. In fact, I've been doing some work in China, and one of the biggest problems the Chinese health system is facing is the fact that they have very high cancers, they have a demographic picture of, old, really a very large proportion of their population being aged. They find that this reliance on tertiary care has actually busted their insurance scheme. That the cost of care for the state has increased phenomenally. So I think there is this problem of it leading to inflation of costs for the health service system. And then there is the public health insurance, like the Ayushman Bharat, and some states have their own. They are focused on hospitalization. They leave out diagnostic services, follow-up, and long-term care on individuals to pay. And also a lot of the primary level work is out-of-pocket expenditure. So what does coping with cancer look like from the perspective of those suffering from the disease and their caregivers? This is another body of literature, and there isn't again very much, but there are a few good qualitative studies which give us these insights. So one of these studies which I'm quoting and I'm going to exemplify is this paper which I have given a reference to, Datta et al., and they actually call for an interdisciplinary approach to understand the complexities of the interaction between the psychological, the experience of stigma, and Dr. Mishra also spoke about fear of the disease, fear which then leads to stigma, decision making and adherence to treatment, economic costs of cancer care and its impact on the household. So I think we are really looking at these very, very interconnected and interwoven set of human dimensions of the problem and how they lead to these complexities in terms of their experience of illness. Next, please. So what I want to really weave back in this is that we need to look beyond just the clinical dimension of how well we can treat. And I think from a public health perspective, how the preventive and the promotive part have to be integrated within the health service system. And here again, I agree completely with Dr. Mishra, who pointed out that, you can't expect the public sector to do everything. There is a large private sector in this country today. And in fact, some of these studies actually show you how people are moving between public and private, between systems of medicine. And because of the very fragmented nature of the health services, the delay in diagnosis and the delay in treatment is really very, very badly affected. I think the way in which the public sector has to engage with the private sector has to also be a two-way process. That is, the private sector should be willing to come into the ambit of especially the prevention and screening programs of the government, strengthen their hands, and at the same time be ethically accountable in the way in which they do the treatment, adhere to standard protocols, etc. The other very important aspect in all of this is to put the issue of networks and collaborations and innovations that are possible as partnerships. I am involved with the Can Support in Delhi, and they have in fact started engaging with the state governments of Haryana, Punjab. They are doing some work with the Cipla Foundation in Maharashtra. So I think we have to look for these kinds of practices, like the Tata Memorial Hospital's example that Dr. Mishra spoke about. But I also think that we need to look at other states where such efforts are being made and learn from them and see how far they are replicable. So my plea is really in this presentation to say that let's look beyond the clinical picture. Let's look at the health system and its interface with people who are suffering, and then expand it even further to acknowledge that there is a human dimension to this suffering, that there are disruptions, and as we all know, cancers have a very long, period of need for treatment, management, follow-up, and this really creates tremendous burdens and stresses on families and on the individual, and then it has a ripple effect in the community as well. So I'll stop here and I'm happy to take questions. Thank you very much.
Thank you very much, Professor Rama Baru. The floor is open for the questions. So the interesting part here is that one of my professor used to say that majority problem in high professionals is that we don't know what we don't know. We fall into the victims of Duncan-Kruger syndrome over a period of time. They said that in order to not to fall on as a victim of that particular syndrome, the most important thing which we often forget, especially in public health program, we are taking the interventions and innovations into the field, we don't understand what is that field. You have clearly marked that very well, and the floor is open for the questions. I'm going to restrict for only 2 questions. Yes, voting. Yeah. And keep the question very crisp and clear and direct. Thank you.
Yes, good afternoon. My question is regarding like psychology, like you might be studying about social behavior of people. So in tobacco packets, it is already written that tobacco causes cancer. So what makes people to choose that path? Like, is it that they have so much work burden, so they want to ease out their work burden, that's why they choose the path, although they know that it may cause on long run very high cost to them and to their family? So, and another thing, like even if people quit this tobacco after some campaign or something, then again some people may be again taking it up, because in biology also we have studied that it is like we get it, means used to it, like people will take more dosage. So what is the psychology in all these things? Yes, thank you.
You know, this you need to unpackage addictions. I think it's like saying that you have to change habits. When you get used to something for a very long time and it eases the pain you have, I mean, that pain doesn't have to be a pain which is physical. It can be an emotional pain. It can be something that gives you some relief. It can be recreational. And I think addictions become very difficult to break because from a psychological point of view, you really don't know what to replace it with. How if I don't have it, then I'm restless, I'm anxious. If you speak to people who are habitual smokers, they'll say it relaxes me. It eases my pain. When I'm anxious, I smoke. So, you know, there is this very vicious circle between your emotional state and you using a prop, whether it's alcohol or cigarettes or gutka or canny or whatever. And it becomes a way of life. It's like it becomes a way of life, and then you're afraid even to kick it up. Because when you kick it up, you do have withdrawal symptoms. We all know that. And you don't feel so happy. And so you go back to it. So I think there is this aspect which is very, very difficult to, that's why it's difficult to deal with addictions. You know, people who go into rehab, come out, are okay for a little period of time, then they flip again. So there is that element of the addiction literature which is very interesting, because there is a biology in it, but there is also a psychology which comes together.
Yep. Thank you, Professor Rama. Okay, I'll take the next question. Like in the with respect to the oral cancer screening, most importantly in my medical school, I've been taught that when we are sitting in the primary health center, where a patient is coming for a free care, my professor used to say that like they have already crossed a lot of hurdles, and this is the best opportunity that where you are going to capture that. Similarly, in a diagnostic pathway, once we mention someone as a screen positive and they are going to a kind of a confirmation, there are multiple psychosocial dynamics happens in terms of seeking that particular care. In your perspective, what do you mention about that?
You're absolutely right, and that's what I was trying to allude to that it can be captured best by a qualitative kind of study. The fact is that this decision to go for treatment, the decision to go for treatment is not just the individual decision. It has a lot to do with the context in which that person lives. Does the person immediately go? Does the person, you know, these are the kind of steps to health-seeking behavior, right? So you have intent. If it is a mild problem, you postpone it. If it is really bothering you, then you start going to the health center. The health center gives you an advice, like you rightly said. But the next step may be quite daunting. It will depend. In fact, there's a study which shows that where you're located matters a great deal. If you are located in a rural and you're being referred to a secondary or a tertiary level in the city, it's very daunting. One is this whole thing of relocating. And for many people who get this advice, they have to relocate and they have to almost live in that city for a couple of months. And which means you have to give up your work. you know, and then it means the part of the family moves with you. So these kind of disruptions that will be produced in both your social and your economic life also determines whether you will take the necessary next action. Or you say, "Arey, theek hai, it's okay, I'll live with this problem, but I can't take all these decisions." So I think this psychosocial pathways to the decision-making process is very, very critical. And of course, the economics of it is even more daunting. Whatever studies we have seem to suggest that even middle class, because you see, Ayushman Bharat covers poor and below poverty line. There's a very large differentiated middle class in this country today that has no insurance cover. I think that is a huge issue because we know families who are in the middle class who are wiped out if there is a person in their family suffering from cancer, because a lot of them do move between public and private sectors. They want to get the best care for their families. And then they end up, you know, selling their assets, selling their jewelry. There are many, you know, people writing about how they had to sell all their family jewelry and assets in order to get the treatment and to make alternate living arrangements. We never think about it like that. But for chronic illnesses, families make alternate living arrangements in order to, you know, overcome this crisis of dealing with a person who has cancer.
Thank you very much.
I don't know if I've answered your question.
Yeah, you did that actually. Thank you very much, Professor. Really thank the two eminent speakers who has thrown important light on real-world implementation. With this, we close this session and over to the organizers. Thank you very much, Professor. Please stay in the online and we have to connect for the next panel discussion. Yeah.
Thanks to the speakers and our chairperson, Dr. Ganesh Kumar Sir, for moderating the session. Next, we have a panel discussion chaired by Dr. Pradeep Kaur, Professor and Chair, IISc Center for Public Health, IISc. I welcome ma'am to chair the session.
I will use the mic because otherwise they can't see me if I sit there. May I invite our panelists, Dr. Gauravi Mishra and Dr. Ganesh here. I think I will be here, so Dr. Rama and Sumita can see me, because if I sit there, they'll not be able to see me. Yeah. You want to move the little bit in the middle, or maybe both of you can sit that side. That will be easier, because then you will also be able to see Rama. Yeah. Thank you very much. I think you all have already heard the introduction of Dr. Mishra and Dr. Ganesh. We also have our colleague Dr. Sumirtha, who is Assistant Professor at the Department of Management Studies at IISc. She's also part of our oral cancer team and is working on health technology assessment. I don't know how good Sumirtha's signals are. She's actually in a tribal area doing field work, a real ground level person. So Sumirtha, if you are able to say hello, you can just say, introduce yourself, because...
Yeah, hello. Yeah, thank you so much. I'm really sorry about the network here, but yeah, I'll try to be as much online as possible. Yeah, thanks.
Thank you, Sumirtha. So I think we will really keep this panel discussion very action-oriented, because we have heard a lot over the last 1.5 days. But as we move forward, I think many of us are actually doing work in this area. And what we want is very concrete action points coming out of this 2-day meeting, so we know, okay, this is where we should be putting our priorities. And I think I believe in working backwards. So if we know this is what we want to achieve, then all our colleagues here who work on technologies, innovation, and so on, I think it will give them clarity on what they should prioritize. So what is that, they can give us in 2 years, what they'll give us in 5 years, what they can give us in 10 years. And also for us to understand which of these innovations can possibly change or transform the oral cancer program, which is really not doing well at all, as we have heard over last 2 days. So let me begin with Dr. Mishra. So Dr. Gauri, you told us about very inspiring work that you have been doing. In fact, I've read also the work before this. This is a very recent good. You shared the workplace stories, but also the community-based work that your team has been doing. So can you share with us what are your key learnings that we can sort of replicate, but also maybe highlight a little bit on contextual challenges. Sometimes we do something, it works very well in one setting, but do you think, first of all, what works, right? Secondly, do you think it will work when we change the setting and the context? So over to you.
Thank you. Perhaps it's a very long question, but then when we organize this kind of camps and we try to reach the population, whoever is doing that, when you're going at the doorsteps, I think it is it is quite easy to get the participation, especially when it comes to oral cavity screening. When it comes to breast and cervix, the context may change a bit. But for oral cavity screening, when you're going at their doorsteps, they easily participate. But once they are referred and you tell them to go somewhere and come for higher diagnostic investigations, especially when it comes to women, they are not the decision makers in the family. So there comes the role of their husbands, their mother-in-law. Everyone is taking a decision except for the women. So we need to take them into confidence. And nowadays what we do is, in any awareness program, we try to see that the spouse is also involved, or the decision maker in the family is also involved, and not just the person who is participating in screening. Secondly, they trust their own family physicians more than us. So whenever we go adopt an area, we see to it that we establish a good rapport with the family physicians and try to tell them what we are going to do. Then we need to understand that when we normally work in low socioeconomic settings, and their cost of transport and the availability of transport is also important. So community, we have patient navigator program, KWAT, that's working in the hospital, but we also stress a lot on community-based patient navigation. So navigating the screen positives to the hospital is something that is important. And lastly, I would say I have never ever taken up a screening program until it is linked to a diagnostic and a treatment facility and an assured provision of how the treatment would take place, because they are all happy in their settings. You cannot go and screen and tell, you have some problem and now I don't know what to do with it. You cannot do that. So unless you are sure about how the diagnostic is going to take place, and unless you have a provision for the treatment, I would say don't take up any screening service. And lastly, I would say that a good awareness program would also go a long way. And what we fail to understand is that we have our own inhibitions, and we think that, these are illiterate population, so it's not going to work with them. And I've seen that I was wrong in several settings. One program that I showed that wherein we did only a single health education program for the contract employees. They were all illiterate. And that actually had so much more people quitting with a single education session. So I think we have our own biases, and we need to recognize and really fight with our own biases before we approach the community. Thank you.
I think fantastic takeaways. And I think there has been literature, I think, also from NHS in UK, where they actually incentivize the dentists to do the counseling during the routine dental checkup to quit smoking, and it has shown good results. Of course, they actually incentivize dentists to do that, like they are paid extra for that. So I think that those are the kind of maybe good research areas that we haven't actually explored in India, and maybe we need to think about that. So I'll move to Dr. Rama now, because I think it's connected to I think what Dr. Gauri started. Dr. Rama, you mentioned, so she also made a note that our referral chains are broken, our health system is fragmented. So now fine, we do this screening program, we find these people. So what do you think is your learning? You have studied the India's health system from a very broader perspective, not just oral cancer. But of course, we are embedding oral cancer within the bigger health system, which is already out there. So what are your sort of takeaways from how to make this work, or are there any strategies that you think we should be prioritizing or testing to make sure that it's not a broken system for the patient? Over to you.
I think one of the big learnings in the present times for any program to really succeed well is to understand that you cannot just say the public sector all the time. I think the private sector has outnumbered the public sector, and there are many different private sectors within this country. And I think what we really require is to first acknowledge that we have, from a patient's perspective, a very fragmented system of care. And that fragmented system of care then requires some form of non-fragmentation to take place, which means that there has to be dialogue. There has to be an acknowledgement of how we build good ethical relationships between the public and the private sector. Very often, in a much unrelated piece of work which I have just completed, it's interesting that you talk about public-private partnerships, but if you speak to the private sector, they say the public sector dominates. They don't trust us. And I think there is a trust deficit in these relationships. And there is also a very aggressive private sector, which tries to set the agenda for debate and discourse. So one of the things I'll really say is that you need better integration between primary, secondary, tertiary, especially in the case of cancers, in this particular context. And we need to build those bridges and partnerships. And that's where I found Dr. Mishra, talking about the need for collaborations as very important. And so how do you build those collaborations? How do you bring back a seamless kind of, at least as infrastructure? And I also want to talk a little bit about different systems of medicine. Again, it's in silos.
Yeah.
Even in a state like Kerala, where they have tried to do co-location of Ayurveda and allopathy, there is no talk. They don't talk to each other. So, in these studies that I have looked at, people with diagnosed even with cancers are going to Ayurveds. They're going to homeopaths before they come back to your allopathic system. So how do we build these bridges? And from a patient's point of view, it's extremely important to acknowledge that we have a fragmented health system. And there's only so much that the public sector can be demanded.
Thank you very much. I think this is an area where there's a lot of gap. I feel in both in terms of testing different approaches, but also even prioritizing it as one of the sort of health system, what we can say, reimagining the health system from that perspective. So let me move on to Dr. Ganesh. Dr. Ganesh, so I know you've been working in several chronic disease over years. What do you think is, first of all, we know that we have lessons, specific to oral cancer screening, we have some lessons which have come from research or from program like today. Dr. Basu's talk in the morning also talked about screening programs in other countries which have shown success. But when we try to take all these learnings to implementation, we have not been successful, right? So first of all, what do you think, what is that we missed there, right? And do you think that implementation research or other approaches can actually help bridge and translate some of these good evidence-based practices to large-scale programs? You could also draw from your learnings from other chronic disease where this bridging might have been slightly better. Over to you.
Thank you very much.
Do you have that mic so they can hear you? Okay, fantastic.
So there are two parts which I wanted to cover here. So the number one is that, like, whatever the evidence being presented with respect to oral cancer screening or the cascades of the care are all in a controlled setting. Some of the things have been done a minimal pragmatic setting, like what Dr. Gauravi has mentioned on the police officers screening, 54,000 police officers, that learning. Some of the thing has been done in a multiple setting with different innovations where Dr. Praveen Baroor has taken those leads. But what is actually missing is that, like, when it comes to public health, I usually go with one important term called scale. It only takes the scale. And when it comes to scale of a public health, it matters is public sector. And that too, it is in programmatic conditions. The current data about that, the programmatic implementation of an oral cancer screening program, its effectiveness and second in terms of its implementation outcomes are totally missing. It is not there under programmatic conditions. What we do have with the existing data from other chronic diseases like hypertension and diabetes is that there are two approaches related to the screening of those chronic diseases. One is called the popular population-based screening, where going to the doorsteps and screen the individuals. Second, which is called opportunistic screening. However, we often don't want to use that word. We call it as universal screening, which means that whoever comes to the health center, you screen for those chronic diseases. With respect to national program for NCD, there are only 5 important diseases: hypertension, diabetes, 3 common cancers, cervical, breast, and oral cancer. Very simple. These are the 5 important chronic diseases. All has similar or closer to the same kind of a pathway and cascades of the care. So what actually we have learned for hypertension and diabetes screening in the current literature from the programmatic data is that the population-based screening will not produce any yield, actually, when it compared to the opportunistic or universal screening which is happening at the health facility. This is what the current evidence which is clearly shown. A paper which is published in this year has clearly earmarked there is no additional yield when we are going to the population-based screening. But the economics are different. In order to do a population-based screening, you need to take huge amount of resources. And you definitely you will miss a huge chunk of population which is working population. Opportunistic or an universal screening has a higher advantage because, as I said earlier, it takes an immediate opportunity. The person has a good receptiveness when they are within the health system. So this is what the current evidence says to the other chronic care. When it comes to the implementation gap, what actually usually say about implementation research gap is that for an innovation or an evidence into a practice or policy, it takes minimum 20 years. I'll give one classical example about hypertension treatment. Amlodipine, many of you must be knowing, there is a drug. The amlodipine evidence was existing for nearly, I would say like 4 or 5 decades, but it brought into the protocol or into the program only very recently, which is just very 2023, 2024. It took nearly 3-4 decades. This is that called evidence to implementation gap in terms of it. Considering all those things, what actually we are really missing a piece here. Dr. Praveen was asking in the previous morning session, what are the immediate action points? Okay, right. We have all the solutions. We have all the technologies. We have all those kind of advancements. But what is the mail missing is that how to deliver it much better to the grassroots. And we often bring this and tie it upon on the healthcare workers. But really, do we know about what actually these healthcare workers do daily? When you are going to introduce this as a kind of one single piece of this information, even asking 4 questions. Do we really know those public sector or even by sake like private sector? For example, I was discussing with one of the colleague, like there is a huge chunk of dentists are there, like whether the screening is happening there whenever for all the patients who are coming to there. So do we really know about it? May be happening, may not be happening. Do we really know whether what are the challenges into that? We don't know. So that don't know is what the implementation research brings on. It tries to understand and study this gap. It brings an information to that. This is the gap that which your intervention, which is and can be AI, it can be a torchlight examination, has to bring upon. So I stop here.
Sure. Thank you so much. And I think that's really important. So we've been focusing a lot on how we can do very good screening, but where, who should do. So those are the questions we should simultaneously answer, because otherwise we will have great technologies, but will not know what to do with them, right? I'll move to Sumirtha now, and Sumirtha has been working on actually looking at, okay, is this whole thing cost effective at all? See, we talked about many things and we can do that, but when you go to the, let's say, national program or senior bureaucrats, they ask you this question, right? Is it worth spending money on it? And what should I spend on, right? So we heard a lot, and although we know that, okay, this is an effective intervention, but there is one more step we need to go and understand that if we do this in real time, and what are the costs associated with it, and where is it that, what the health outcome you get for that money you spend, and only then we'll be able to actually talk about scale or taking it, countrywide. So I'll just turn to Sumitha. Sumitha, when you were reviewing the literature on oral cancer, did you find data gaps? Since now we are, as you might have heard, we are thinking of like what could be the priorities for research if the research community which is working on it has to kind of look at in terms of what should we really do in the next 2 years, next 5 years to move the needle on the oral cancer, saving lives or reducing the morbidity. So do you think there were data gaps which we need to bridge so that we are able to do at least better evaluation and answer some of these questions? Over to you, Sumitha.
Yeah, thank you, Pradeep. Am I audible?
Yes, you are very well audible. Yes.
Yeah, okay. So there certainly is a lot of data gap in the literature, both related to the cause as well as the outcomes, which is particularly related to oral cancer. If I have to talk about oral cancer, we do not really have information about what is the actual travel cost the patient has to incur, right? What is their wage loss? How much does what is the wage loss or the time that is spent by an ASHA worker or health worker, right? So there are such cost gaps in the cost information of these parameters that we did really feel that, and we do not know exactly, like by looking at the literature, about what is the region level information or facility level information. When we come to the field, the experiences are entirely different from model it. We oftentimes equate it to an equilibrium number, like a macro number, which would be more suitable. But then when we come to, for example, I'm in the tribal area where it's like 2 hours inside the forest, right? So you just have to imagine that if they have to go to a hospital, how much they have to really spend. So if we are actually targeting this population, then obviously the challenges are going to be different. So I did feel that there are data deficiencies in terms of the region-specific information, the patient-specific information, and the system-specific information. But nevertheless, the evaluation that we conducted were based on certain set of assumptions. But I'm sure that when we actually go to the field, we might have to relax these assumptions, or we might see that the results are quite different than we modeled it to be. Yeah.
Thank you, Sumitha. I think those were very helpful points. We should really be measuring more of that. Do you also want to mention in terms of health outcomes where you felt there were data deficits?
Yeah, definitely. So this is something which is something which has been missing overall in the economic evaluation studies, irrespective of country and irrespective of the diseases. If we look at the quality adjusted life years, which is usually the outcome, or the life year gains, that is the outcome. Now we do not really have a standard parameter which would say what is the quality, right? How do I measure the quality? So we do have certain questionnaires and certain information which is pre-filled, but I would say that probably if we get those informations from the patients, then it would be more appropriate outcomes, right? So right now we actually look at the quality adjusted life years, or number of disability years that the patient can reduce, or the number of disability years that gets reduced due to an intervention, or number of years that the patient can just live more irrespective of the quality, right? So these are some of the parameters that we look at in terms of the quality outcomes that we measure. Yeah.
Sure, thank you. And coming back to you, Ganesh, I think you heard from all our panelists. So as we go forward and we design newer studies, can you think of what should be the key parameters, contextual parameters, which should be measured, like in context of making our implementation research more robust? And also if you can reflect little bit on the importance of geographical variation and context. I think this was pointed out both by Sumitha and Dr. Rama. And then I think I would like Gauravi to also answer the same question. And also maybe, Dr. Gauravi, when you are answering this question, you can also reflect on different settings, because you have seen that this context may change. So, so in our own experience, we know when you design the program for community versus when you do it as a clinic-based or in what we call as opportunistic, and we like to call it universal, that everybody could be screened. Actually, the thinking process changes, and certain implementation, even the technologies change. For instance, what you can do in a, let's say a clinic, even if it's most peripheral, is little different from what you can do at a household versus what you can do as you move up the chain to PHC. So can you think of, Ganesh, you can begin with that and Gauravi can add on. What is that you think we should be capturing, measuring? Also not just from the disease perspective, but also from the health workforce perspective, time of nurse and the setting and so on. Over to you.
Thank you for that question. So what I've been hearing for these past 2 days from all the researchers and technologists is called that efficacy research, which tells about the efficacy of that particular model or the efficacy of that particular intervention. Then slowly we move to the effectiveness research, which is about like pragmatic trials done in the real world setting, like what actually Professor Mishra has mentioned about that. But what is that? The third part is what we call as an implementation research. There are certain specific designs which actually captures both the clinical outcomes and as well as implementation outcomes. And those implementation outcomes matters a lot, which answers the question called how it works, what are the factors which favor or hurdle the implementation of that particular intervention, and third is that why it works in that particular setting. These are actually captured very well in the implementation research in its outcomes, and there are one few, or we can say it is called acceptability, fidelity, adoption, adherence. In morning, Partha was mentioning about those 3 different outcomes on structure, process and outcome measures. All those things are all falling on these kind of implementation outcomes on that. What it encompasses, how it is going to be different from usual effectiveness, efficacy research is that. For example, I will take this example of what actually Professor Mishra has did that like. So they did this introducing an worksite intervention for oral cancer screening. What actually here it worked is that they found this is the yield, this is the total number of people who has lost to follow-up. Okay, right? But what actually is the most important barrier or the facilitator for those people who come to care? What are the barriers for those people who are not receiving that particular care? And second is that like why actually this works here among the police work professionals, but it is not working in cab drivers. This context is the most important thing, and I borrow some of the principles from design principles and design thinking, where it actually matters a lot. The user is the most important person. Here the user for our oral cancer screening is healthcare worker. Do we know about that particular healthcare worker better? It can be dentist, it can be a ASHA, it can be an ANM, it can be an MLHP, it can be a CHO, it can be a nurse, whoever it can be. But do we know them better? Have we observed them in their own setting? Do we know how they work? What are all their working conditions? You are going to even introduce one paper of a questionnaire, how it actually halts. These are the things which actually this implementation research concepts prevail to it. Over to you.
Thank you. So I will deal with it a little differently. First of all, I know that this is a meeting of oral cancer, but I would still like to stress here that if you're going for oral cancer screening and you don't do the NCD screening and don't do the breast and cervix cancer screening, it's a lost opportunity. And your program will definitely, I'm not a specialist in cost effectiveness, but I'll tell you the program will become definitely much more cost effective, because the same staff, any population level intervention, it's the manpower cost that is the highest, and the same manpower can do all this, and we have tried it in different settings. Secondly, when it's a rural area, it's really difficult for the screen positives to come to the hospital for a checkup. In that scenario, what we do is, we call it a mop-up camp. What we do is we make a list of all the screen positives from that particular village, and our doctor goes there, because the primary screening is done by the primary health worker. So our doctor goes there on an appointed day, and all our workforce is there to get the screen positives to that particular camp, so that the clinical diagnosis is established for sure. And in case of oral cancers, what we do is we do a brush biopsy at the campsite. So that is the minimal thing that we do. And similarly, we have adopted it for cervical cancer screening, another wherein we, though pathologists and gynecologists, some of them will not agree with me, but in some remote rural and tribal setting, we have to do screen and treat. So VIA and screen and treat, and that is the way forward. So it is contextual. It is not that everywhere you can do what is the most ideal thing. Secondly, we all are literate, and so are our family members, right? I don't want an answer, but just reflect on this. How many of your mothers, your aunties, all about 30 years, have got themselves screened, right? We are talking this in educated families. So it's not just the literacy rate, but what matters is also the acceptability of the screening that we are talking about. So when yesterday or today someone was speaking about oral self-sampling and screening, I was very happy about it, because we saw it in COVID times. If you give something that the participant can do themselves, it's much more comfortable. When you see the easy usage of the pregnancy kits, right? I mean, it's so simple to use. So just to give you an example of, things work differently in different settings. Taking an example of cervical cancer, I was doing one study wherein we had urban slum women, urban non-slum, and rural population, again different contexts. And when I was looking at oral slum women, I was really bothered to know what is happening. Where will they collect self-samples? I mean, they have a common washroom facility. There is just one room wherein 10 people are staying. So though it may be really something that I feel, oh, every woman will accept, but where is she going to do it? In rural context, if I give her a pamphlet, will she be able to read it? Even if it's pictorial, will she be able to really understand how to collect it? So the context and different settings, they play a very different role, and you should really look at very different stakeholders, understand what are the real issues, and try to understand the barriers. And for all Indians, I would say that the importance of health is never understood till it's lost. That applies for us also. We never really pay attention to health till we really fall sick. So when it comes to workplace, again, unless you have complete cooperation from the management and union, you cannot make a difference. So everywhere your stakeholders really differ a lot. Maybe there's some spiritual organization where whatever the religious leader says, everyone will follow. So you should know which stakeholder to really catch hold of, and you should know at what time your awareness should be. In many of the rural areas where it's farming sector, we actually do the health education in the evening times and night times when they are back from work. So the context really matters. We also work in tribal settings, and there again the issues are very different, and how to handle it, and that also is very different. Yeah.
Thank you so much. That was so good. I think both of you have given a lot of ideas to our innovators and tech people here. So I think what I can summarize is that, can you make the job easier, right? And can you make it work for a particular context? That's what technology should be able to do. Because if it becomes, if it is complicating the work, or if it is not fitting into their workflows or the cultural acceptance, then sorry to say, technology fails. So I think those are some of the key points, and keeping not only the disease clinical outcomes, but also the programmatic outcomes and the outcomes in terms of implementation, which should be built into the research studies that we design going forward, because we seem to be really good in designing efficacy research, but we are not able to move beyond that. So those were great takeaways.
Dr. Prabdeep, I'll just like to add one. Sure. Oral cavity cancer screening, just example I remember from the field. So this WellScope was introduced several years back, and there were people from the American Cancer Society. They came to us to teach how to use a WellScope. Even I had never used it. So I said the best setting is, let's go to the community. You will get so many pre-cancers and you can easily teach us, So when we took them to the field and they saw some oral cavity, they said, oh, we don't know what to do. So I said, why? What's the issue? So they said, no, this is very different because all our oral cavities, because we use so much smokeless tobacco, they were either pan stained red or they had melanoplakia. So the melanoplakia also appears dark and your lesion also appears dark. So they said, no, I mean, this is very different and we don't know what to do about it. So I think, again, sorry to take it, but the context really matters. So when you're, what works perhaps in Western regions may not work for our situations.
And the variations within India are huge, as we have seen in our own experience in the last 1 year. So, Dr. Amma, any thoughts? I think you may want to sort of mention little on the social aspects and the other determinants which need to be captured too. So I think people are always worried about finding what doesn't work. But in my own learning, what I realized was, I mean, not in my initial years, but later years, it was actually more important to understand why something worked. And quite often when you start analyzing why something worked, there were a lot of local context-specific factors. And since you work at a broader, so I mean here, like you can even think broader, like there is political, there is social, and there are many other contextual factors that make a certain intervention work. Same intervention doesn't seem to work in another setting. So your thoughts on that?
Yeah, I'm very glad that you've been speaking about context, and I think context is extremely important. But I'm not just talking about a geographical context. Yeah. I think the socio-economic context is absolutely critical. You know, it's very interesting that even the work, I mean, the NSSO data can help us disaggregate across SC, ST, income quintiles. Yeah. But you know, gender doesn't come at all. How do women experience the disease? What kind of support do they get from families? You know, and where do they neglect? Where do they ignore? Where do they give up? Because we've seen this in some of our diabetes work. And you see a stark difference in the management of diabetes and hypertension between women and men across classes. And you know, and in a sense, the program becomes very demanding, saying you should take care of your health, you should be going, you should be doing. But the dynamics of the home overtakes women. I mean, you're rash, and there is a very interesting and a very, it may be useful for your implementation research, you know, conceptualization, which is rationing. People are rationing, you know, at home. They're rationing time, they're rationing priorities, they're rationing money. You know, so rationing at the household level is a very live, and we ourselves ration. If you examine our own lives, we're juggling. We use the word juggling, but it's rationing. So you put your priorities last, you put somebody else's priorities before you. And I just want to add one other dimension, which is very complicating, is age. As families have aged people and young people, there is a very interesting piece of work being done on how do people in their middle ages get squeezed between the demands of the two genders. So this intergenerational demands become very important in the way families make decisions. Who gets included, who gets left out, you know, how much will you do, and then you fall off the map. So, you know, that is one. And I think, you know, I don't know, maybe this is a dimension which could be used, is to actually build a community of sufferers and survivors. You know, I mean, as support groups of how you cope. I've seen this in the case of mental health, even in cancers, but I don't know how prevalent it is and how useful it is. But I think there is something to be said for some kind of a psychosocial support which goes beyond just your family, because even caregivers need support. Absolutely. Huge gap, huge gap.
Thank you, Dr. Amma. That was very, very important points. Sumita, anything you would like to add on in this context? What do you think we should be measuring when we design our research beyond the standard clinical outcomes that we focus on?
Definitely, we'll also have to measure what is the overall benefit for the society, because that is basically the intention with which the technology is sort of developed, right? So it's not merely the clinical outcomes, but overall we would like to have a better quality of life for the society. Now, I think in the previous conversation which I was hearing was also related to, like, can you increase like the number of diseases that can be screened, right? So there's also this economics of technology which talks about, can you just like, probably after a point, we'll also see that the economies of scope takes in, right? So if you can increase the number of diseases that a particular device can screen, then obviously the cost of it would reduce. And also simultaneously, we've been talking a lot about economies of scale, that let's just increase the number of population that we can screen. Definitely per person cost is going to reduce by that. But we do have an economy of scope playing as well, which is also something that can be explored for the longer run, to see that if we can reduce the cost per screening, right? And another point is also something which is related to AI, because right now we are working on AI, which gives a sensitivity score of something today, probably an improved one a month later, probably a much more improved one a month later. So that is also something that I feel that, okay, even as we see that the technology, effectiveness of the technology is improving, so should our cost effectiveness also improve. So that's something that we are currently working on, which is like a dynamic modeling, where with the increase in the sensitivity of technology, we can always say that, okay, what is now the incremental cost effective ratio? Otherwise, we'll have to like really go back and then do the entire manual work, which is not worth. So that's also something that we are currently working on. And longitudinal data, of course, like, because we definitely need to see what is happening at each stages. Right now, it's all based on assumption. There's going to be like a 10% increase, 20% increase, etc. But can we really see it at the field level, what's really happening with these samples that we have selected, right? So if we can get those information, probably the ICER values that we are calculating could be more closer to the accuracy. And I'm sure that it would also benefit a lot of policymakers in making a decision, because oftentimes the policymakers that I've spoken to, the bureaucrats are worried that, we've got this intervention, but it's not effective at all. It could probably because the data or the assumptions that we have made could be somewhere not realistic. So that's also something that I probably feel is would be beneficial. And since it's an action research, we are not just building a technology, but we are also making sure that the technology reaches the society and it gets the intended benefits, right? So I think these are some of the things that I can just like probably think about. Yeah,
I think these are very important points. And I would let the audience ask few questions before we close. Dr. Prakash, someone can give mic. Please give the mic with so the online speakers can hear about it.
Thank you very much, all the panelists, and very interesting discussion. I will just take one particular point, which I thought I would comment. I would like to extend the point made by Dr. Rama, and that is on social suffering due to oral cancer. Because a person suffers, when there is oral cancer, the patient suffers a great deal. And we all, those who are nearby, family members and everybody else, can sympathize a lot, empathize a lot, can help a lot, but it doesn't result in action. It doesn't result in action at personal level or societal level. And the reason I think is also there, that is our Indian philosophy and mindset, that everything that happens to us is due to our karma, either in this life or in the past life. So it is very difficult to take action on somebody else's, they are suffering because of their karma. But what Dr. Rama said about social suffering, that is very important. That goes beyond that. And we have a very good example, illustration of how does social suffering creates a change. Dr. Pankaj is not here right now, but Dr. Pankaj and I and few friends, Dr. Pankaj conceptualized and this voice of tobacco victims. And what we did was, in this project, Dr. Pankaj simply took an oral cancer patient to a very influential group, generally chief minister, MLAs, IAS officer, big lawyers, and didn't do anything, simply put that oral cancer patient in front of the crowd. And the oral cancer patient talked about his own story, life, suffering, what tobacco did to it. It was gutka most of the time. And we were there at the background just afterwards to give scientific credence or data on that. And this particular example of social suffering created so much action that we have the evidence. I mean, we know that gutka has been banned in every state.
Yes.
And gutka has been banned in every state simply because of this particular kind of approach. So my question to you, Dr. Rama, is how we can extend this concept of social suffering, its measurement, research on it, and its dissemination, because that might be very effective in terms of making a change. And this is something that I think really calls for action, next action. Thank
Dr. Rama, you got the question? Yeah, okay. Please go ahead.
Yeah, it's very interesting that that the human stories can be very compelling, but there will always be this tension between how do you measure suffering? What is suffering to me is it suffering for you? But I think that's why I used another term, which was, how do you measure disruptions? How is that measurable? I mean, I was very happy to hear your colleague, Sumita, that, how do we measure disruptions to a person's, it's not just to an individual's life, but what happens dynamically across both the social and the economic aspects of it. And I think I was part of the Health Technology Assessment Committee of the ICMR formerly. And one of the things I used to keep telling them is that please build social dimensions. Don't do economic evaluations in that Markovian model, And so I used to always say that we have to bring equity into the discourse. We also have to bring, because technology is not a neutral entity, I mean, you can have irrational use of technology. I'm not moving away from the question of social suffering, but what I'm saying is that we need to somehow realistically look at social suffering as an experience, but you can measure the disruptions it causes. Yeah. Can you quantify? I think some other speakers have spoken about it. What does it do to livelihood disruption? What does it mean if you lose a job? Then nobody is coming in. The state is not coming in to fill in the gap, right? And therefore, you don't have unemployment insurance or anything like that. So I think it'll be interesting to tease this out in terms of disruptions. That's why I alluded to even community of sufferers. I know they've done it for TB survivors. Yeah. Some NGOs have tried to document what happens in their lives. It could be compelling for policy advocacy. It could be compelling even to sensitize various constituencies, including medical professionals, nursing professionals, and going beyond the health service system to the politicians. Does it capture you? Does it move you? It may. And I think one needs to think of innovations in that area. But coming back to your question, I think social suffering as a framing and looking at disruptions to tease out what it does to populations and different strata of the population.
Thank you, Dr. Rama. I think we can take maybe one more question, one or two, maybe
it's
two
not
more
a question.
Yeah,
Just
make it little
suggestions
quick,
on
your
the
question.
metric. Yeah, yes. I'm straight on it. It's on the metric. Those
detected pre-cancer
Yeah.
upon total cancer could be a metric. And particularly if you consider the opportunity cost that are not pulled or trapped into poverty, the family escaping the poverty, that could be another metric. And third is I am interested as a volunteer on the implementation side, design, testing, and kind of that. Development engineer. I'm a development engineer, so I'm a volunteer. So you can also measure as a metric how many volunteers are there.
Okay.
Thank you.
Fantastic. I think that was more of a comment than a question. Is there a question, Raghu? Yeah.
Yeah, it's a question. You just mentioned TB. On TB side, there's a lot of mapping around patient pathways. Where do you actually go to seek care first, so on and so forth. And there's a lot of, I know, a lot of research on what are the intervention points, where are we losing patients. Has there been similar such work done in oral cancer, where we really understand patient pathways, and hence we know where we should intervene and where AI could actually make a difference?
Anybody want to answer? Yeah, Ganesh. Yeah.
We attempted for the cervical cancer, but not for oral cancer. But I just, that's a direct answer. So if you ask me like what we call this also from the design principles, storyboard techniques. We try to map the patient's typical day when they are coming to a health center, what are the things they undergo. We try to map that with another group who is working on cervical cancer in order to introduce a self-sampling. We try to draw all the pathways, what all they will undergo, what they need to face a question when they are asking that, go and lie on that particular table in that particular position, and I want to introduce a speculum, what will be their, the feel of the patient. We try to document that particular pathway, and it was very insightful for many people who are involving the cervical cancer program, in order to convince why you need to introduce self-sampling rather than the usual visual inspection by acetic acid. When you just put an acetic acid into an reproductive tract of a female, how it feels to that female is most important thing. We try to tell that too, because majority of this cervical cancer or many cancer are more than males, more than panels. So there are male dominant things were there. We try to bring that to for an understanding. For oral cancer, so far we reviewed the literature and we didn't find this kind of story, but maybe Professor Mishra can say about it. That could be one important attempt. We need to do that. Like for hypertension and diabetes, we tried during our India Hypertension Control Initiative. Is that like I did this personally when we introduced in Chennai Corporation, which are operating in urban primary health centers. We introduced this hypertension control initiative. One day I simulated myself as a patient, went to an urban primary health center. I noted all the time how much time it took for me to complete the registration and what are the instructions given to me. I went to the nurse, whether she checked the blood pressure correctly, she saying all these things, went to a doctor. All these things I underwent through the entire pathway to understand really when we were introduced this India Hypertension Control Initiative in slums of urban primary health centers. So likewise, that is the thing that we need to do that. And there are certain design principles, our colleague Mahima is here, so where we have learnt in our IISc work also, like when we introduce an app to a healthcare worker, first we need to understand who is that healthcare worker and what are their busy hours. Are we introducing a problem to them in the name of technology? Are we really making their life easy?
Yeah.
So those are very important.
Yeah, so Raghu, just to add to your answer, so there is actually studies done in India on oral cancer, but what I have seen, I was recently reviewing the literature for something else, this whole approach, like it is gaining more and more traction in the literature. So earlier we did not have so many studies on this patient journey, but I looked at the literature and I saw that there has been actually like real very sharp rise in the number of papers, and interestingly a large number of these papers are on cancers, but not many from India. So maybe that is another important takeaway that we should be looking at as a research thing.
The reason I asked that question is
yeah.
an observation that the design of the AI depends on
exactly
the point of usage, who uses
exactly yeah. No, I think we need more research on that. Yeah, yeah. We'll take one last question and I will close the session. Yeah, yeah. Okay.
This
Okay,
question
two
is-
questions, that's it.
This question is to
Be
Dr.
quick.
Ganesh, sir. Sir, whenever something new is rolled out in the program, there will be so much of concerns from the healthcare workers, be it ANM, be it ASHA, or be it any healthcare worker. So, I mean, the integration of oral breast and cervical cancer has been started in the program in 2016, and it's been around a decade. So there definitely like many concerns would have come. Apart from the acceptance phase of DABDA of the healthcare workers and force from the government, are there any interventions which were actively tried on that concerns? And this is more of a health system research question rather than an IR question. Yes, sir.
Mike is there, yeah.
So just wanted to mention that, like, really speaking, there is no conversation never happened when they introduce any programs. This is one thing very point blank. There is no conversation. It's top down. Like, this is the program, these are the guidelines, follow it. That's it. We tried this exercise when we wanted to introduce a program called patient support groups for hypertension, diabetes in Tamil Nadu and Kerala. So for that, we brought all the MLHPs, mid-level health providers who are at Ayushman Arogya Mandis to a meeting. They are the only people like were there, and we spoke to them and asked about it, like, is there a scope that you can do in patient support group? The answer is yes and no. But when I asked the question, like, if we can do it, how better we can do it, or how it is not should be a botheration to them. So they came up with a strategy. Then I say, if I am going to take a report for your purpose, how do you think this report? They designed a report. They designed the register. And then they have also participated in this. But honestly speaking, there is no consensus elsewhere. No conversation happens in a program. That's an answer for that.
So I can partly answer that. There have been several evaluation attempts, I would say, because government doesn't like evaluations. So yeah, I mean, academics like us do it, and we have actually come up with what is not working, why is it not working. But the problem is we are not able to bridge that gap between the policy and the practice. So there's a lot of work to be done there. Yeah, last question. Yeah.
So I find opportunistic screening.
Yeah.
I think that's a bit. I feel like it is like give the crying child the milk first.
Okay.
So I would rather say that. Okay, I understand that you want to save money and you want to be as cost effective as possible. You want to increase the yield. So I think one could go about it by doing figure out so now you have a lot of data saying that okay, these people are infected, we know they are in this locality, so try to figure out patterns where you're able to pinpoint okay, this area has a very high chance of being you have a very high chance of finding people who are infected, and then there you be unbiased, there you go to every house, so maybe you could have a trade-off in that sense.
So I think his question is population-based opportunities. You want me to answer, Ganesh, or should you? So, yeah, I think so. Just to clarify, it's not like that. Opportunistic screening is not people who come to doctor for symptoms. I think we didn't clarify the definition. Opportunistic screening is anybody visiting any health clinic for anything. You may go to a dentist and say, I have dental pain. Or you may go for fever, but you get screened. So opportunistic screening is more efficient simply because these people have already come into health facility and you have a doctor who can examine. So that doesn't mean you are leaving out others. What happens in population-based screening is we don't have an evidence that it is effective in improving any outcome, because when you reach out to people at the home and say, I want to screen you, I mean, what we know, I mean, of course, for the cancers, coverage is 2%, so that's almost negligible. But even for hypertension, diabetes, they say, I'm perfectly fine, you are coming to my house and telling me I have a problem. That's your problem, not my problem. So usually what happens is people never go for care. So that's why it is more effective. So we currently do not have any evidence that population-based screening programs work. Even all the evidence, morning Partha also told, in the cancer screening comes from what we call as organized screening programs, which are mostly from Nordic countries. So I think it's a complex topic. I'm happy to give you more insights later. But we do not have any evidence that population-based screening improve any outcomes. So that's where we are. Maybe it may happen in the future, it might, if we are able to change the population behavior. And if we are able to make maybe testing available much closer to the patient. If I'm screening and telling now you go 200 kilometers away because I think you have a problem, and as they all told you, patients will be walking around with oral cancer and say, no, I don't have a problem. You understand? So it's complicated. See, that's why this whole discussion was around, like, it's not, sorry to say, it's not maths. It's not 2 + 2 4. The implementation of a health intervention is really, really complex, and there are many dimensions. So I think let's close on that note. Thank you very much to our panelists online and here. Thank you, Sumirtha, Dr. Rama. I think you brought a totally new dimension, and we all are going away with a lot of new ideas, and not forgetting the social suffering as one of the core ideas we need to keep in mind as we work on all these conditions. And thanks, Gauravi, for excellent work that you are doing, and there's a lot we need to learn from you. We are going to bother you a lot, and thanks, Ganesh, for all the insights from the field. Thank you organizers for the opportunity, and especially want to thank Professor Rajesh, although he's an engineer himself. I think he has a very good sort of, let's say, focus on public health, and he actually felt that we should have this session. So I'm grateful for being inclusive in adding all these disciplines to what was a very clinical and technology-centric two-day meeting. Thanks a lot.
Thank you so much. Lovely meeting all of you.
Yeah. So I'm just closing the call now. Sumirtha, thanks. Thank you, Ramana.
Thank you. Thank you, Prabhi.
No, I'm okay.
Thank you, ma'am, and all our panelists for their insights and expertise. I now invite Professor Rajesh Sundaresan to deliver the vote of thanks.
Thank you. I think 2 days of intense meetings. So let me begin by thanking the organizing committee members, Dr. Praveen Birur, Dr. Anupama Shetty, Professor Devnath Pal, and Professor Pradeep Kaur. Thank you very much. I think we have had a program that involves all systems perspectives. I was just making some notes myself. From the behavioral implementation to epidemiological, clinical, molecular, genomic. I think we had all of these aspects covered over these 2 days. That's a full systems view, and I think such a view is needed to be able to get close to the lofty goal of elimination of oral cancer. I would also like to continue to thank the Oral Cancer Task Force members, Dr. Moni Kuriakose, Dr. Pankaj Chaturvedi, Dr. Vijay Chandru, Dr. G.K. Rath, Dr. Kumar Prabhash, Dr. Govind Babu, and Dr. Praveen Birur. Thank you very much for thinking of the Indian Institute of Science as a venue for this, and also to Biocon to give us this opportunity to have a forum where all of us could meet and think about this important problem. Also, I would like to thank Professor P.C. Gupta and Dr. Kedu Vinuwo Keditsu. I'm meeting them for the first time. I think Dr. Keditsu I'd met very briefly on a previous occasion, but I think the wealth of your experience has actually enabled us to understand what are the things we ought to focus on. So thank you very much for that. Additionally, several people have come a long distance to attend this. Dr. Samir Anthani, I don't know if he's around. Dr. Anil Chaturvedi, Dr. Milind, yes, yeah, there he is. Dr. Partha Basu and Tony Ma, thank you for your contributions, for joining online, for taking the time to do this. All the speakers, panelists, chairpersons, thank you very much for coming today yesterday and today for joining us for this. Also the several AICOE partners that have come forward to join in this program. Thanks to you all as well. Well, we have to thank the volunteers. There are several of them. Let me begin with Dr. Shika, who was the one that was running the show here, Dr. Lakshmipati. Yeah, there he is. Dr. Monojit, thank you very much. And volunteers from IISc, Leena, I think she has been the backbone of the organizational aspects for this conference. Tejashwini and Sushma, who were outside this morning and yesterday with the registration. Manoj, who helped us with the technical setup. Where is Manoj? Yeah, thank you very much. Tarun, who has been around making sure that everything works smoothly as well. Thank you, Tarun. Ms. Geetanjali, who helped with the posters and the outreach. Nayan, Manohar, and of course our other support staff over there and several ECE staff members. So I would like to thank all of them. I would like to end with the following perspective. So I think Dr. Rama Baru mentioned that we have to stop doing Markov models. Well, when I heard that, I sort of felt that I connected a little bit with those tobacco addicted individuals, because in some sense I am addicted to Markov models. And whether if you ask me to stop, I would say yes, I will try my best, and then I'll go back and do my Markov models. So in some sense, I think that's the kind of issues that perhaps we are facing. It's a challenge, a societal challenge that we ought to address. And it requires all components to come together, all of us to come together, all of us to work together in such a way that we put the problem ahead of us rather than thinking about perhaps this is my work or this is somebody else's work. Think more about this as a bigger problem that we ought to solve and come together to solve that problem. So that we have done that over the past 2 days. It's a good start, and let's continue to do that. Thank you very much.
Thank you, sir, for your kind words. As we conclude this 2-day event, on behalf of the organizing committee, we extend our heartfelt gratitude to each and every one of you for making this event a success. Thank you. Now please join us for high tea arranged in the reception.